Good afternoon, ladies and gentlemen. The commission will come to order. I just want to note for the record who is on call. We have Dr. Pollack. Is Commissioner Hammerslaw on the call, or Commissioner Peters? Okay. Anyway, all right, fine. We have a quorum. Ladies and gentlemen, your first agenda item, as always, is the minutes of the last meeting, December 20th, 2018. You've all had a chance to get copies of the minutes and read them. I would like to entertain a motion for the approval of the minutes of the last meeting. So moved and seconded. Any further discussion? All those in favor, say aye. Aye. Any opposed? Minutes are adopted. The commissioners, you've all had an opportunity to read the written updates from the centers of the commission. There's a lot of valuable information. A number of these things are quite detailed. Commissioners, do you have any questions at all for any of the directors of the center or the staff on anything you've read with regard to the written updates? Any questions at all? I do have a question. I guess this would be for Ken Yates Trotman. Ken, can you help me for a second? You're following the price transparency issues. Just one thing for the record. The CMS has announced its price transparency initiative for hospitals. Now, we're under a waiver. So the question is there anything that the administration is doing in this area that would impact anything that we are doing in the area of price transparency, to the best of your knowledge?
Well, the only thing that I could say is that as far as the commission, in terms of the commission, we are looking to expand the way to call the website, and also to expand also the professional services. Sure. Reporting as far as that website is concerned. Right. So as far as expanding, the way to cost website, I think that is how we are actually expanding the price transparency.
Right. Okay. Well, what I would like you to do between now and the next meeting is looking at what the administration is proposing. Mm-hmm. If there's anything that you think is problematic for the commission, in other words, basically that would in any way preempt what Maryland is trying to do, if there's any kind of potential conflict between the state of Maryland and CMS. Okay. If there's any kind of issues that you see, there probably may not be. We're under a waiver. We have a different set of rules. But anyway, I would like you to just look at that. Okay. and prepare a memo for the commissioners. The other thing I just noticed in the updates is that there was a precipitous drop since October in the number of people who are visiting the Where the Cost website, and that was related to the ads. Is there any way you could elaborate on that at all?
Well, it has to do with because we don't have any new data. So people would go to website when they have new information to really look at. Okay. So right now we are in the process of updating the website with the Medicare information. Right. So I think once that information gets updated, then that will be new information that will entice customers to really visit the website.
Okay. Yes, Mr. Director.
So our public relations team is probably shed some more light on this. So Megan, if you want to come up here, as she's getting situated, I did just have a conversation with counsel to the HSCRC about the transparency requirements that were imposed on hospitals nationally, and I think it would be helpful to get a definitive statement on what HSCRC is doing regarding the requirements that the Trump administration announced on January 1st. I think the requirements have been pretty roundly panned as not particularly useful for consumers. The New York Times, I think, had an article that you had to be a brain surgeon to try to figure out charge masters. So I think we're doing something that is in the same spirit, but in a much more thoughtful way than what the federal government is starting out. But of course, we will be delighted to work with our federal partners in explaining our approach, and I think it is through some of your efforts somewhat known about what Maryland's doing in terms of price transparency.
Yeah, I just want to make sure that, to be very frank, I just want to make sure that they do not do anything that undermines the progress that we've been making in this area. Okay.
So I would say, with respect to the reg, I haven't seen anything that would suggest concerns for me. With respect to the website usage, I would say, in addition, so anytime we do an organized campaign, as we did in July, and continuing on for several months after that, both with advertising and with press outreach, you're going to see a bump in website usage, and then it is going to drop off when we don't sustain those resources. In addition, we've had a gap in contractors, and so that also means we have less staff resources to sort of keep up the social media push that's free. So we're doing our best, but we'll be bringing on new contractors soon. So we'll solve it.
Thank you very much,
Yeah.
Megan. It's a very reasonable explanation. Executive Director, do you have any additional updates?
So a very short update today. Earlier this morning, we delivered our first briefing to HGO. It was a overview of the Commission's activities and plans for the next year. HSCRC, Behavioral Health Administration, and others were presenting after us. We didn't stay due to the meeting, but it seems that our presentation, which focused on our strategic priorities as generally, and our price transparency efforts in particular, were generally well received by the members, both those that had been on the committee and a couple of the newer members as well. So that was just an overview. This afternoon, David Sharp is presenting in Senate Finance on the school-based telehealth effort. We do have a briefing on February 7th on the CON reforms, which I think in terms of activities for the Commission, focused specifically on our responsibilities, will account for the bulk of the time that we spend in Annapolis over the next 3 months. There are other issues, but the CON reform issues, I think, are attracting some attention in Annapolis already.
Okay, thank you. Any of the Senate directors have any additional updates at all? Okay, fine. Before we move on to the action items today, I would remind all of you that under state law, we have pretty strict ethics requirements. We try to make sure that we separate any kind of private interest from the public interest that is, of course, well and proper. If you feel, for any reason, that you feel that you must recuse yourself in consideration of an agenda item, please recuse yourself, move to the conference room next door, and the staff will let you know as soon as the Commission has completed action on that agenda item. And the record will show that you were not a participant in that determination. So once again, this is something that you and you alone would know, whether in fact you might have a conflict of interest. Okay, the first action item we have is a certificate of need application. Western Maryland Home Health Agency Review, the Adventist Home Health Services. This will also include, I guess this is Amedisys Home Health and Beata Home Health Care. Commissioner Marcus Wang served as a reviewer on the application. applications by Adventis, Amedisys, and Bayada, each of which wants to expand its provision of home health services in all of Western Maryland, parts of Western Maryland, all of Western Maryland. The territory covered here would be Allegheny County, Frederick, Garrett, and Washington counties. You've all received Commissioner Wang's recommended decision. None of the applicants notified the Commission that they desired to file exceptions to the recommended decision of Commissioner Wang. So there will not be an exceptions hearing today. Instead, Commissioner Wang will present his recommended decision, and we will vote to accept his decision or not. Here today on behalf of Adventist Home Health are Keith Ballinger, President of Adventist Home Health, which please stand, thank you, and Howard Solins, the council. Howard, welcome, it's good to see you again. Keith, thank you. Representatives of Amedisys here today are Jeffrey Braskin. Jeff, thank you. And Vice President of Operations, Marta Harting, counsel. And representing Bayada will be David Perea, I believe, is that correct? And Patrick O'Malley, is that correct? Welcome all. Thank you very much. Commissioner Wang, you reviewed the applications. You've studied the case for the applications. The floor is yours.
Thank you. Thank you, Mr. Chairman. So today's matter involves expansion of home health agency services into certain jurisdictions in the Western Maryland region, which for this review consists of Allegheny, Frederick, Garrett, and Washington counties. And the three applicants we have today, as the chairman said, are Adventist Home Health Services Incorporated, Amedisys Maryland, also known as Amedisys Westminster, and Bayada Home Health Care. Adventist and Amedisys seek our approval for a CON to expand into Frederick County. Bayada is seeking to expand its services into all four counties, Allegheny, Frederick, Garrett, and Washington. So first I'd like to note that each of these three applicants is in fact a high-quality provider of home health agency services in Maryland. Each of them met performance-related criteria set by the Commission, qualifying them to expand their service area in this review. Now, under the policies in the Home Health Agency chapter adopted by the Commission back in 2016, each of the four counties in question shows the need for additional home health agency providers. Two of the counties, Allegheny and Garrett, have both insufficient consumer choice of providers and they have a highly concentrated market for home health agency services. Frederick and Washington County, they both need new providers because both jurisdictions have highly concentrated markets for home health agency services. Frankly, and I'll be honest, I wish that all of the applicants had applied to expand all four jurisdictions to serve the people living there. Now, our commission has made a commitment. We want to increase the access of Maryland residents in terms of choice of high-quality home health agency providers. We have a great commitment to the public good. We want to increase their access to quality services. And it's through those lenses that I reviewed these applications. After the initial review, we determined none of them were approvable. So we held a project status conference. Adventist did a great job, and they quickly made the needed modifications. We sent another letter to Amedisys and Bayada about their additional changes, and Amedisys made their necessary modifications to several standards. Now, Bayada has sought to expand all four counties, which helps address our policy goal of providing residents there with additional choice. And so for that reason, that desire to expand all four counties and serve our fellow Marylanders there, I looked at their second modification, responding to the Charity Care Standard in the most favorable light. And I found that Bayada met the minimum requirements of that standard, and I will recommend two additional conditions to be placed on its CON if the Commission adopts my recommended decision. So I would move that the Commission adopt the recommended decision and approve the application for all three applicants, Amedisys, Adventist, and Beata, with the following conditions. Number one, each applicant must maintain compliance with the provisions of COMAR 1024-16 regarding charity care, a sliding fee scale, and reduced fee services. Number two, each applicant must provide an amount of charity care equivalent to or greater than the average amount of charity care provided by home health agencies in that region. So for Adventist and Amedisys, that's Frederick County. For Beata, it's Allegheny, Frederick, Garrett, and Washington counties. And number three, each applicant must provide documentation regarding its links with hospitals, nursing homes, continuing care retirement communities, hospice programs, assisted living providers, adult evaluation and review services, adult daycare programs, the local Department of Social Services, and home-delivered meal programs located within its proposed service area when it requests first use approval. And with regard to Beata, I recommend the following additional conditions on their certificate of need. Prior to the partial or final first use approval, Beata shall develop separate forms acceptable to our staff and commission to implement its determination of probable and final eligibility for charity or reduced fee care. And prior to partial or final first use approval, Beata shall provide us with information regarding additional steps it's taken to assure us that it will provide an amount of charity care equivalent to or greater than the average amount of charity care provided by home health agencies in the Western Maryland region. Finally, I would like to thank the Commission staff for their hard work and professionalism they've demonstrated in the processing of these applications. In particular, I'd like to single out our Assistant Attorney General Sue Ellen Weidman, Kathy Weiss, and Sarah Pendley for the tremendous work. They've paid tremendous attention to detail. They poured through thousands of pages, records, minutiae, precedent, and regulations, all in order to serve our mission, to improve access to quality health care for all the people of Maryland. Today's applications mean a great deal to me as someone who has spent some time in Western Maryland. Rural health care is one of the Commission's priorities. And it's my hope that if the Commission adopts this recommended decision, Amedisys, Adventist, and Beata will continue to work hard to serve the needs of our fellow Marylanders who live there. So therefore, I'd like to make a motion, Mr. Chairman, that the Commission adopt the recommended decision as a decision and award a certificate of need to each applicant under the conditions recommended.
You've had a motion. Do I have a second for the motion? Commissioner Tamarchio seconds the motion. All right. Now, do we have any further discussion? Yes, Commissioner O'Grady.
This question, I think, is probably for you, Commissioner Wang. So we see three applications here, only one that is covering all four counties that are sort of in focus here. Any idea why it's not a 3 out of 3? Why are there any barriers? Is there anything bureaucratically? Is there any reason that only one is willing to go all the way to the West Virginia, all the way to Garrett? And is that something that the Commission needs to focus on, work on, et cetera? Just again, with this concern about access for kind of what I think of as the Appalachian counties in Maryland.
Absolutely. Thank you, Commissioner O'Grady. It's an excellent question, and one perhaps that the applicants themselves are better prepared to answer. As I said before, I would prefer that they all expand to the 4 counties.
I think that's a fair question. Councilor Solomons?
Automatically, I'll come up with Mr. Ballinger.
Sure.
Oh, yeah. Adventist Home Health is already a multi-jurisdictional home health agency, and I'm here with the president of Adventist Home Health, and Mr. Ballinger can speak to these particular jurisdictions and why it's been an incremental approach.
Good afternoon, everyone.
Yes.
When we embarked on looking at one of the adjacent counties, we have 7 counties, and Montgomery County is one closest to Frederick, having 2 large hospitals in the Montgomery County area with a lot of patients that when you look at where the density is with the Frederick, that was our initial interest to service those patients as well. And we do have an Upper County office, which in the application we said we would be running that out initially, and then looking at the growth down the road there, that we would establish an office there, which would allow us not only to provide services in Frederick County, but then to look at adjacent counties moving forward if there was an opportunity. Which what we didn't want to do is apply for all 4 counties and not be able to serve them, just to sit on the CON and know, because we know that we're going to be able to provide the quality services and density there. That's when we first looked at that county there. But for the future, once we have something established there, absolutely, that would be an opportunity to grow, because we realize, because we're in Southern Maryland counties too, so we know we know what rural territory is, and used to be in Eastern Shore as well. So we wanted to do smart growth, efficient, keep the quality services there, and look to expand from at that end.
Any further questions? Oh, yes. Oh, sorry. Excuse me.
Thank you, Mr. Chairman.
Hi,
Mark,
how are
on
you?
behalf of the
Good to see you.
Medicis Commissioners. I think you're going to hear a similar answer from the Medicis. I think an incremental approach. They're going to be establishing a new office in Frederick. I think they're very interested in looking towards in the future, towards future growth, but didn't want to sort of bite off more than we can chew at this point.
Yeah, I absolutely agree. Very similar response. We wanted to make sure that we would be able to be successful in moving west, and as opportunities continued and we stabilized that new care center, we would then hopefully expand further west.
Thank you, Mr. Abraskin. Any further questions?
Can I ask one follow-up?
Yeah, sure.
Yeah, is there a demographic sort of aspect here? I mean, DC is a very expensive metro area, so I can see a very logical sort of, especially among retirees, sort of, sell that house in the close-up suburb, move to Frederick, that sort of. Are we seeing that sort of underlying trend here? Are the Appalachian counties picking up population, especially among the elderly, or is that me projecting a little too much from, DC area home prices? I, for one, don't want to pay those DC area home prices, so I understand what you're saying. I would say from the research that we saw and looking at the statistics, there's a greater population density in Frederick than further west, and the growth rate didn't seem as exponential as it is in Frederick.
Yes, Commissioner Sargent.
So the western counties in Maryland are not exactly compact, right? They're long and skinny. I was just wondering, in expanding westward, is that something that in your business you would do going through the state of, out through the state of Maryland to expand, or would there be a sensible service model for your business that is centered on servicing Pennsylvania, Maryland, West Virginia, from a location?
So, and yes, for a Medicis, we actually service that area of West Virginia. We have the office in Morgantown and surrounding areas, as well as in Pennsylvania. So there's definitely opportunity as we go forward. We really just wanted to focus on standing up a new care center, getting good at serving that population, and then having the opportunity to move west.
Thank you.
Okay. Mr. Abraskin, Ms. Harding, thank you very much. Any further? Wow. Okay. Gee whiz. Talk about communications. Are there any further conversation? Any further discussion at all? All right. Well, then let's. Yes.
Commissioner Wang, the population out in West Maryland is not that great. What is the ratio of, or the expected bed availability per hospital patient in West Maryland? I mean, are all 3 extending at the same time? Will there be enough business for everybody?
Sorry, Commissioner O'Connor, you're saying, do we think of the population out in West Maryland?
There's so few hospitals out in Western Maryland. Home health usually gets patients from hospital referrals.
Right.
Is there enough?
Yes, we've made the determination that in terms of the density, in terms of the competition, that there is in fact a need, and so we will approve for them to go out there and expand the services.
Okay, any further conversation? Any further questions, discussion? We have a motion, we have a second. It's time to vote. All in favor of granting the application of a certificate, for a certificate of need for these three agencies, please say aye. Aye. Any opposed?
Aye.
Congratulations, ladies and gentlemen. Thank you very much for coming. All right. You're welcome very much. Okay. Our next item is increasing public awareness of the healthcare quality reports on our consumer website. And during our November 2018 meeting, the staff presented a new introductory video that is will be posted on our quality reports on our website. Our contractor created a 30-second promotional video for airing in local movie theaters through the end of March. This is a fresh approach to healthcare public relations. But today, Courtney Carta, Chief of the Hospital Quality Initiative, is going to give us an overview of the project and describe our strategies to increase public awareness on our consumer website. Courtney?
Thank you very much, Mr. Chairman and Commissioners. So we were fortunate enough to be able to present to the Commission a couple of times in 2018 and give you a demonstration on how to use our website. Some of the common feedback that we heard each time was, well, that's great, but what are you doing to let the consumer know that this information is available? So we really wanted to talk to you today about our strategy and some of our preliminary results from our advertising campaign. And we'll also talk to you about what we plan to do for the remainder of 2019. So when we think about our website and the message we want to deliver to consumers, we know that our message has to be simple and direct. Our goal is to really help consumers make informed decisions about their care. We also want to help patients and families be able to compare and monitor performance. And we also want to be able to provide resources. So even if it's not something that the Commission can help a consumer with, we can point them in the right direction. We do get a lot of calls in that aspect. So our audience is quite broad. So our primary focus is consumers, not only patients, but also family members, as well as caretakers for seniors. We do have an extensive amount of information for long-term care services. We also get a lot of calls from different industry stakeholders, including providers, employers, policy professionals, and advocacy groups. So we've engaged in several different types of marketing strategies in the past. So as we were getting the website up and running several years ago, we engaged the consumers in focus groups. It would not be a great thing to have a consumer website without the input of a consumer. So it was really beneficial to us to help us see what kind of information they would like and just how it appears and how it would be usable and actually visually appealing to the masses. We also put out press releases if there's any information that's relevant or new. So for example, back in the fall, we put out a press release about the Leapfrog hospital safety grades. We were also able to link back to our website to get a little bit more exposure there. We've contributed to articles and news stories with local news affiliates. We've also written articles for federal newsletters about some of our hospital-acquired condition or healthcare-associated infection activities. We partner with different state agencies. So one example is the Maryland Hospital Association. They do link directly to our website on their homepage. And they've also corresponded with hospitals themselves to see if they would be willing to put our website on their the hospital's website itself as well. And back in 2016, we did have a small marketing contract where we were able to develop radio ads, Facebook ads. We also created a banner and these rack cards that we put in your packet. So we're able to take that those materials with us if we go to any local conferences.
So this is just a picture of our team. We recently attended a local conference put on by the Health Department, the Office of Minority Health and Health Disparities, Health Equity Conference. So our team takes the approach that it's all of our jobs to really promote the site. So we did have an exhibit table, and we recently purchased some promotional materials. We left some stress balls. Our motto is learn more, stress less. So hopefully you can enjoy those. We've got some hand sanitizer. We also have some chip clips and some bags. So we've got a lot of different things. People are much more willing to talk to you if you can give them something in return. So people love free things. We also engage in social media. So we do about 20 posts a month on Twitter and Facebook to try to link our followers back to the website. And we've also been experimenting a little bit with paid advertisements. Obviously, you get a boost and your engagement and your reach increases if you're willing to pay. So a while back, we had this idea to develop an animated video. We thought it would be a great way to engage users and be a little bit more interactive and sort of be a how-to on how to use our site. We do have so much information that sometimes it may be overwhelming. So that is the video that the chairman alluded to earlier, the 2-minute video that we were able to show you back in November. So we actually do have our contractors here who helped us from Rock House. So I just want to introduce them. We have Megan Yarmouth and Floyd Yarmouth. So they were really great in helping us be able to bring that concept to life. So out of that 2-minute video, we also created a 30-second video that we're using for our advertising campaign that we want to share with you today. I got it right in November. All right, sorry about that. Okay. So the shorter video you probably recognize because it's just a shorter version of the 2-minute video. So the longer video we plan to just put on our homepage of the website because it gives them a little bit more instructions on how to use the site and how to navigate. But the 30-second video is what we're using for our advertising. So we actually have that 30-second clip on YouTube right now. And prior to the meeting, I heard somebody say they just saw it. Yeah. So thank you. I eavesdropped on your conversation. So we know that's working well. In addition, as you mentioned, we have the ad being played at movie theaters across the state. So the ad is being shown at 49 movie theaters. 36 of those theaters are NCM. So those are some of your larger theaters, Regal, AMC. And then we have the ad playing at 13 different Screen Vision theaters. So the neat thing about that is those are discount theaters. So those are $4 and $5 tickets. And a lot of those theaters reach some rural areas as well as Baltimore City. So we have a large reach. I think the theaters cover almost all counties in Maryland with the exception of 4. In addition to the on-screen ads, there are also the videos being played on lobby monitors. So if you're getting your concessions, you might see the ad. And we also have physical scans in each movie theater as well as digital banner ads on the website. So we're only a couple of weeks into our campaign, so our results are preliminary, but so far encouraging. I was able to run the Google Analytics for the first 4 weeks of our campaign compared to the same time period last year. So we're seeing a 32% increase in use from the same time last year. But I think what's more striking is that we have almost a 42% increase in new users. So it's tracking IP addresses that have never visited our site before. And the 26% click-through rate I mentioned, that refers to our YouTube advertising. So what that means is whoever is getting our ad, they're watching the entire 30 seconds. The number was 26% last week. It's gone up to 29%. So we hope that as we kind of target our audience a little bit more, that'll continue to increase. And just for context, industry standard is 20%. So we're well above that. And we did hear back from our contact at the movie theater. He sent us some anecdotal comments from moviegoers. Some of the comments say that the ad is eye-catching, the message is clear and concise, and people are now aware of our services that they were not aware of before. So all things that we're going for. So we just included some pictures. The two on the end are of the ad at the on the movie theater screen. The center picture is one of those lobby monitors I mentioned in the concessions, so you can think about your health while you're putting butter on your popcorn. So we'll continue this current promotional effort. As I mentioned, we're still in the thick of it, so our results are still preliminary, but we hope to be able to give you an update in the spring. And we think of this as a stepping stone. It's been a really fun project, and we kind of see this as maybe the first in a series of projects or additional videos. We've got a lot of data, a lot of different topics we could create videos for. And also, videos take priority for social media. So if we're able to link it to our Facebook and our Twitter, we'll likely get more hits. So in the future, we thought about potentially expanding to other mediums, so radio, TV, maybe bus ads, as well as expanding our audience targeting. So we'll also continue our networking and collaboration with other state agencies. We know that's something we can't let up. And we also do have more focus groups planned for later in 2019. So we do have some plans to revamp our long-term care guide and develop our outpatient guide. And so we do, of course, want to include the consumers in that, as well as making some more modern, making the website a little bit more updated. So I'm happy to take questions for feedback.
Thank you very much. I think this is clever and creative. Thinking about cooperating with state agencies, I can't help. I mean, what about the DMV? Seriously, Department of Motor Vehicles. I mean, the poor people are standing in line, and they usually go to the wrong line and got to come back again. It's time for us to occupy some of their time creatively. Did you ever think about that?
We didn't think about that.
Oh,
but
okay.
we will now.
So it's a new idea. Okay. All right.
So I want to just quickly, I'm not sure if she's here today, but Andrea Allen is MHC staff in procurement, and this was really her idea, and she was really instrumental in moving this forward. So I just want to recognize Andrea for her thoughts in this.
Great idea. Terrific. Thank you. Commissioner O'Grady.
Congratulations. This is very nice. I wondered, again, with this idea of what other possible audiences, what about all those kind of constant rolling videos that you have when you sit in a waiting room at a physician's office or things like that? Because clearly the person's mind's already on healthcare, the idea. And I didn't know whether that was doable. I don't know anything about that industry, how you get on those sorts of, Joan London has to approve or, whatever. But again, that might, if you haven't already explored that. The other thing is on the flip side, as we gain more and more exposure, what kind of efforts are being made to make sure just kind of the internal kind of readability of the website, the usefulness? What is the plan there for kind of, years ago I had unfortunately to go to the National Cancer Institute website. I was just amazed at how, they could focus on researchers, they could focus on providers, they could focus on consumers. It just seems, they must have million focus groups to get that refined to the level that it was. And I didn't know kind of what we were doing there. It seems as we grow, we better have better content to keep up with the new audience.
We completely agree. And of course, this is resource dependent. So we do, as I mentioned, we have the focus group planned. So we try to do that frequently or occasionally if we can. And we do know that the website is evolving. So we are constantly trying to think of new content and what would be useful for the consumer, but even more audience groups in the future.
Director?
So we should also note that this procurement, these contracts being recompeted now, we expect that there would be some competition with other vendors that might have other proposals. We'll keep you posted on that. But it is slated for a major overhaul. I think the data, given that there's no major data refresh going on right now, if we do see any growth, it can be attributed to the campaign as opposed to something new that caught everyone's attention. We're also right now not getting any earned media attention on the site. So basically, our public, the impact could be attributed to the media campaign. I did have one question that maybe for Courtney that was posed to me earlier today, which was if you've been to a movie recently, they tell you not to use your phone. The impulse would be to use your phone on this. What's our strategy to make sure that people actually capture that web address when they're watching this? Some don't have good a memory that they can recall, so they see this and they leave the theater and it's sort of lost in the excitement over whatever they saw. So do you have any thoughts on that?
Well, so one thing I will say that is a drawback is the website address is very long, so challenging to remember. It's something that we've struggled with for a long time, but we're bound by certain rules with the state. So the good thing about the movie ad is it is very early prior to the trailers for other movies. The lights are still on. So they have not made the announcement yet to put your phones away. So maybe banking on some rule breakers. But also we do have that the ads in the lobbies and as well as the stands and the online ads.
Commissioner Thomas.
So I really like the outreach, to the community. And communities are so hungry to be spoken to with respect, like these ads do, that they may well pick up the telephone and call the commission and ask for help with my grandmother has diabetes. So my question is, are people picking up the phone call asking for medical advice or help calling the commission versus going to the website looking at the data on the commission?
We get those calls all the time. So I'm not sure if they're related to the ad, or a lot of times they'll Google and they'll stumble upon our website and give us a call.
So how's that triage?
If they call, it depends who they call. And so if they call the main helpline, whoever answers here in admin will direct it to the appropriate center.
I think monitoring that might be quite important. Maybe it's more, like you say, it's been happening anyway, but with these kind of ads, it might increase. Again, how you do the handoff is really, really important. You've got a nice positive buzz, but you may hand them off to somebody that turns them off. You need to know what that referral might look like.
Thank you.
Very good point. Commissioner Tamarkin.
Just following up with what Ben said, I think one way to address that would be working on leaving a thought of what the search term would be, like how you would search it and what would come up, and then trying to do the strategy behind making sure that you're coming up first on the search. But that would be the solution. Nobody remembers what they Google.
Any further questions?
Quick one. In terms of getting around not getting around, that's the wrong attitude, but that the state has certain standards about websites. there's no ability to do an alias that is simply sent to like marylandhealthquality.gov or something. I mean, certainly the official one would still have all the periods in the right spot for state standards, but there'd be some little alias site that you could sort of, that would be really easy to remember.
We have looked
quality, you know, if it's something short.
we have looked into it. So far, we've been unsuccessful, but it's something that we're still considering as our next contract ramps up.
Okay. Thank you. Any further questions? Thank you very much, Courtney. That's been excellent. Excellent. The next issue is the coverage and reimbursement for emergency medical services. Looking into new care deliveries, and these are a series of reports that are required pursuant to Senate legislative actions. The General Assembly passed legislation in 2018 that directed the Commission and the Maryland Institute for Emergency Medical Services Systems to study reimbursement for 3 EMS healthcare delivery models, emergency medical systems. Now, staff work closely with the Maryland Institute and HSCRC, of course, and MDH, and members of the emergency medical services community, as well as payers, and looked at these issues. The staff has already shared a draft report with the commissioners earlier this week, as you know, and the Emergency Medical Services Board has already reviewed and approved the report. The report was approved on Tuesday. This report describes the challenges that are faced by EMS. It reviews the models, 3 models under consideration, discusses their funding streams and the challenges to public and private payers for implementation of these kinds of models. I want to emphasize that this report does not recommend legislation for 2019. It does conclude that the models under consideration show promise and recommends continued support for pilot studies to further determine how these programs can improve patient care. Megan Renfrew, who's our Director of Government Relations and Special Projects, is going to present this report and fill us in on all the details. Megan?
Well, first, I think you gave me a promotion.
Oh, I'm sorry.
That's okay.
Come on, Molly. You deserve it. Right?
Yes. Oh, thanks. So I'm going to talk today about this report, which we provided you all earlier in the week. I'm going to spend the bulk of the time going over the recommendations to give you a strong sense of what those are, but I want to lay a little bit of groundwork first. I know I've talked to you all about this before, but just for review, this was requested during the last legislative session under Senate Bill 682, and the bill gave us a set of tasks. We were to study reimbursement for 3 services: emergency medical services without transport, otherwise known as treat and release; emergency medical services with transport to an alternative destination, meaning not an ER, most likely an urgent care center or possibly a behavioral health stabilization center; and then mobile integrated health services, which provide care in the home. We were to develop a plan for Medicaid reimbursement, a process for Medicare reimbursement, and report on findings and recommendations related to the private market insurance sector. This charge was given to MHCC and MIMS to run together, so this is co-led, and membership and participants included hospitals, providers, insurers, components of MDH, most importantly Medicaid, HSCRC, MIMS, which has regulatory authority over EMS, our commission, and local EMS jurisdictions throughout the state. We had a state steering committee where we had a large number of meetings trying to work out our understanding related to Medicaid and Medicare policy. And then we had 3 work group meetings with a larger stakeholder community. We also had a number of one-on-one meetings, one-on-one not being quite, but individual meetings with insurers and their representatives to sort of gather information before the work group meetings. And it did go through the EMS board yesterday, and they were quite supportive of the report, or not yesterday, Tuesday. So to review, there are 3 models that we looked at. So the first one I'm going to talk about is treat and release. There are 2 types of treat and release that are discussed in the report. One is routine, everyday part of EMS's business, where EMS is called, somebody calls 911, EMS responds, they deliver care on the scene because it's an appropriate thing to do, and then the person refuses transport. Because EMS is reimbursed currently as a transportation service, EMS receives no reimbursement for whatever services and supplies they deliver on the scene if they do not transport that person to an ED. In addition, there's space for innovation in this area. Baltimore City in West Baltimore is working on that now. They have a program called Minor Definitive Care Now, where they have a doctor and nurse or nurse practitioner on call in a chase vehicle, so that when the paramedic identifies that they have a low acuity patient on scene, the chase vehicle comes and provides care on the scene, and so that person doesn't have to be transported, but they're actually getting a higher level of care than they would have gotten if it had just been normal treat and release. And that's subject to a pilot protocol that was developed by MIMS through their process, which involves some extensive review. The Minor Definitive Care Now program is grant funded. So moving on, oh, I'm not using my slides. Somebody should have interrupted me. Moving on to alternative destination. EMS, under this model, they transport somebody to an urgent care center or a similar environment. So in Baltimore, that could include a stabilization center, which is focused on behavioral health. Right now, there are pilots going on in West Baltimore and in Montgomery County. And again, these programs are grant funded. And then finally, we have mobile integrated health, where EMS partners with other healthcare providers to provide home visits to people who are either frequent 911 callers, frequent users of EMS transport, which there's some big overlap between those 2 categories, and or people who are identified by partner hospitals as being at high risk for readmission. And they do home safety checks. Some of the programs do medication reconciliation, and they do referral. There are 7 pilots in Maryland, again, all grant funded, all subject to MIMS protocols. So moving away from those models, just to talk big picture, there are sort of 2 components of the EMS system. There's public safety EMS, those are our public EMS programs and services, and then there's private EMS, which provides transport in between facilities. I'm focusing on public safety EMS right now. Public safety EMS budgets come from a combination of county and local funds, and in most jurisdictions from billing insurance. And then they may have additional funds, grants, fundraising. Some folks who live in rural areas may occasionally go to a fire department supper. So they have a mix of funding sources, but it's partly county money. Currently, public safety EMS is reimbursed for transportation from the 911 point of response to an emergency department, and it's reimbursed as a transportation service. Medicaid pays a flat $100 per trip, period. Medicare and private payers pay based on complexity of the transport and mileage. And so that brings us to the recommendations. First, we had some sort of overarching vision statements. These are that the models of care need long-term sustainable funding to continue and grow, that reimbursement must be financially and practically viable for all system participants, including payers, that reimbursement should include private and public payers to avoid cost shifting between the payer types and ensure equitable treatment of consumers regardless of insurance source. And then finally, the EMS reimbursement changes should line up well with the total cost of care model, right? We want to support that model. Oh, yep, sorry. All right, so that's the one I just talked about. And then turning to Medicaid, we had 2 recommendations that MIMS and Medicaid should continue to work to develop reasonable cost projections for these 3 models of EMS care through increased collaboration with local jurisdictions, managed care organizations, and MIMS. And then that Medicaid should include studying these 3 models of care as it considers developing total cost of care savings initiatives. Moving on to Medicare and HSCRC, and I apologize for the extraordinarily small type size here. The HSCRC currently has grant programs, and one of their grants funds the West Baltimore programs. And so we're encouraging HSCRC to expand grant opportunities for these care models, to allow EMS programs to apply for grant funding. It would have to be in partnership with local hospitals to fund these programs. This is conceived of as a bridge until while we do further study to understand what's possible with respect to reimbursement. And then the other points here are about HSCRC considering these models with respect to developing new tracks under the total cost of care model that would allow for partnership between hospitals and other forms of providers, and that this might be an opportunity to bring this, these programs into play under Medicare. I would say we're seeing some signaling from the federal government that they may change some Medicare policies related to EMS reimbursement overall, and I'll have updates about that in a month or so if we actually see change that we're hearing rumors of, in which case that may impact what HSCRC thinks about these things. But this is what we know right now and what we recommend right now. Okay, and then a set of recommendations for MIMS and MHCC, which focus on MIMS developing alternative destination designation process. The idea being, how do we decide where ambulances should go if they're going to an alternative destination? What kinds of locations are acceptable for that? So they'd have some way to designate urgent care centers. And then a number of items related to collecting and analyzing more data, doing further evaluation of existing data, and continuing to work to address data issues that may be preventing our ability to fully understand these issues, and continuing the conversation with stakeholders. And then finally, some recommendations for public and private payers, or not quite finally, that public and private payers particularly are already grant funding in this area and doing some interesting support for some of the pilot programs. But we encourage them to consider implementing creative pilot models using these delivery models, including experimenting with payment approaches that have been adopted in other states. Some other states have moved farther along towards reimbursement than we have. Hospitals similarly have been supporting some of these pilots, and we encourage them to continue doing so, and similarly for payers. And then with respect to data, as I mentioned already, current data is a barrier to understanding the cost by insurer or insurance type. The data that comes out of MIMS, the system that the paramedics use, doesn't have insurance information in it unless that person is delivered to an emergency room, which means for the treat and release patients, there's no insurance information, which then makes it hard to make a business case to insurers about how many patients we're seeing in that context. So that's a place where we have some improvement to do and further study is needed. Finally, the legislative committees could request that we assess the impact to private insurers under an existing statute. And so that's something they could opt to do. That would give us some authority to do some more in-depth actuarial analysis. So, so as I said, the EMS board approved its report on Tuesday. If NHCC approves, then we'll submit it to the General Assembly. It is possible that they will request briefings on the report recommendations, but at the same time, we expect to continue work with respect to study, data analysis, and stakeholder engagement.
Thank you very much, Megan. Before we go into further conversation, Vice Chair Pollock has some observations on this report. Andy?
Thank you. Can you hear me okay? Barely. I don't know if there's a way to turn the volume up. Not being able to hear me is not a usual problem. I want to first congratulate Megan and the crew on an excellent report and for outlining a very complex series of issues around the topic. I want to highlight just a couple of things that I think are important for folks to understand in reading this, and a couple of points that I think are important for us in the conversation going forward to clarify. First of all, with regard to mobile integrated health, it's important to understand that that is dramatically different than typical EMS responses, in that mobile integrated health represents a proactive response to reaching out to a patient at risk rather than the reactive response of a typical 911 call. And it's been demonstrated in other areas of the country to be a very, very effective method of keeping people from calling 911, from getting into a situation where they need to call 911, and keeping people out of the hospital, which is in line with our total cost of care model and what we're trying to accomplish. What we need to consider in thinking through this with regard to payment for mobile integrated health services is the degree to which this overlaps with what home health agencies are doing right now, and the degree to which there's overlap with the role of the care transformation organizations in organizing the home health response for patients. We don't want to create duplication of services where it's not necessary unless that results in competition that leads to better care for patients. And I didn't see a discussion of that in the report. I think it's important for us also to understand that the home health agencies are operating under certificates of need, or receiving certificates of need prior to operating, and that this could be viewed by them as a way around the certificate of need process to enter the same market, particularly as soon as there's a reimbursement associated with it. Both of those things are important for us to consider. The second thing I would point out that I want us to keep in mind as this goes forward is that a lot of this impetus around the concept of treat and release in the field and taking patients to alternative destinations rather than the emergency department, some of it's driven by cost factors, but a lot of it is actually being driven by the recognition by EMS providers that as soon as they arrive in an emergency department, they're likely to wait for a prolonged period of time before they can go back in service, before the emergency department takes possession of the patient. That is outlined nicely in the report, and I think it's important that we outline that with the legislature. But in conjunction with MIMS, I think this represents an important public safety issue that we need to highlight for the public. And I think we ought to be tracking times between when an ambulance arrives and when that ambulance is allowed to go back in service by the emergency department, and we ought to be reporting those times. We know the times that we have and the information we have suggest that Maryland is one of the poorest performers in the country in that regard. And I can tell you as the medical director of the Baltimore County Fire Department that that represents an important threat on a day-to-day basis to the safety of our citizens, because every minute that an ambulance is waiting in an emergency department is a minute that it's not available to respond to a 911 call for assistance. And that impacts our response times in Baltimore County on an everyday basis, and we're not unique in the state. I would say that that's probably true for most of the jurisdictions in the state and certainly for all of the major metropolitan jurisdictions, and it's a huge threat in Baltimore City on a day-to-day basis. So the to-do for us, I think, is to start to monitor those things that are driving some of the impetus for programs like this, like the treat and release, and like the alternative destinations. That's all I have right now.
Dr. Pollack, let me ask you a very specific question on this. You've made some rather important observations here, in that you're asking members of the state legislature, I guess, to consider that. Now, that's not included in the report. You wouldn't, you're not opposed, for example, for us releasing this report, are you?
I think the report's excellent, and I would encourage us to release it.
No, okay. I just want to make sure that your remarks are not in any way meant to delay the report. But let me follow up with this observation. Is there any way, Megan, and is there any way in the letter in which the commission transmits this information to the state legislature that we could include these kinds of observations as commentary to the committees, to let them know, or to let the legislators know that these are items that have sort of come out of the commission discussion? Because it seems to me that, what Commissioner Pollack is talking about is as serious as a heart attack. I mean, we've got to make sure that they understand that, it's a little bit more complicated than a lot of people realize.
Mm-hmm.
This is a deeper issue in many respects. I will just simply say, because I have a member of my family who is involved in doing emergency medical services for the fire department in Anne Arundel County, that I hear stories all the time about the misuse of services, people who are going to hospital emergency rooms who ultimately should not have gone to the hospital emergency room, an abuse of the system. I'm sure it's going on. That's another side of this. Obviously, we're not going to conduct some kind of an investigation into all of this, but these problems they plague the system, and we have to do it. Commissioner Reimer.
Yeah, I thought it was an excellent report. The comment I wanted to make is that the issues that the EMS folks have is that there isn't a lot of financial incentive not to transport because they're not getting paid. Mm-hmm. So we really need to align the dollars, and certainly for hospitals, I would think that this would be important. They don't want these patients showing up in the emergency room, generating large dollars of cost, increasing their total cost of care. So I would think this would be something that everybody would rally around and realize that we can use those same dollars in a much more efficient way and reduce some of these other problems that we're seeing in the emergency rooms.
Just a couple of comments. Thanks, Megan. Great report. Dr. Pollack mentioned differentiated reactive versus proactive type of visit. I'm just curious as to who makes that decision and when to make this cost effective. Secondly, there's no mention of secondary transfer of a patient delivered to the hospital who needs to be transferred elsewhere. I don't know how that fits into this mix of costs of ambulance transfers. I guess that's it.
So taking the second question first, that secondary transport, so from the hospital to somewhere else, is largely covered by private ambulance companies. And I do have to say, in our conversations for this report, we largely focused on the public ambulance companies and their responses to 911 calls, which is something that is their particular responsibility. That said, the private industry is very interested in these program models. They made that very clear. So I don't want to suggest, so I think if we, they want to be a player and are supportive of these changes as well. Can you repeat your first question? I'm sorry.
There was a mention of differentiating a proactive visit versus reactive visit. Reactive meaning probably needs to go to the hospital. Proactive, like
no.
this is.
So meaning 911 calls are reactive, right? Somebody calls you and then you show up and you don't know who they are, and you provide them with the care they need, but they're already having a problem. The mobile integrated health programs look at they focus on three populations: frequent 911 callers, frequent ambulance transport callers, and people at risk for readmission. So there's sort of two ways people get identified. One is that the EMS jurisdiction looks at their data and sees who their frequent customers are, and then reaches out to them and asks for their consent to participate in a mobile integrated health program, so that then, with the idea, saying, we will come to you, we'll provide you with education, we'll provide you with services, we'll provide you with referrals, we'll help you figure out how to do this in a way that's easier and better, right? But they're looking through their data and seeing who is it who's doing this often, and focusing on the people who are the most frequent users, right? And then the other is hospital care managers or discharge managers on discharge being like, I'm a little worried about this person, and so I'm going to call EMS. I know they have this cool program, and say, can you keep an eye on this person? They've I've asked, they've consented, and they're interested in having visits.
Well, we have those proactive agencies right now. I was thinking of a patient frequent flyer who calls 911 board, well known to the board, and instead of sending an ambulance, they send home health out to the patient. Is that a concept that's considered, or is that too far-fetched?
So here,
you don't send an ambulance, you send a home health nurse.
So in the mobile integrated health programs, it's a team. So it's EMS, and then usually some higher level of provider, a nurse practitioner often, and then sometimes a community health worker. It's a team that's going. So whether that is the equivalent to what would happen if you sent home health instead, I think that touches on that point of like, how do we think about these services when we have lots of different programs that could offer similar things? I think it's similar when you talk about referral and care management also.
Well, you said you'll send a chase car, so to speak, with a physician or a nurse practitioner.
That's for the treat and release in West Baltimore.
What's the cost effectiveness of that? How many of the people do you treat and release to make it cost effective with payment to the EMS?
So that program has really only been running for 2 or 3 months. So that's one of the points when I was talking about not having sufficient data. This is one of those cases.
All right, thanks.
Yeah.
Commissioner Sargent?
I think it would be good to include the need to look at the appropriate cost sharing and the list of things that you're going to the cover level when you decide payment. What you don't want is a system where we're now paying $100 for people every time when they want to go to the urgent care center, they call 911.
Right.
They get their ride to the urgent care center. It costs $100, which was the cost to transport someone to the hospital. There needs to be appropriate incentives in place so that if somebody can get themselves to urgent care, they get themselves to urgent care.
Right. If they could take Lyft for $6, you'd rather pay that. Yeah.
And you don't have Lyft everywhere in the state, but
right.
You can take a $6 Lyft. We don't want to pay $100 to send an ambulance.
Good point. Commissioner Thomas first, and Commissioner Thomas.
So, excellent report, and I may have missed something, so I'm going to ask you a question.
Yep.
You mentioned that they get paid when they transport.
Yes.
Okay. Now, all the hospitals I know in the state of Maryland are trying to reduce the readmissions, trying to keep people out. Okay. So, is there an unintended consequence on the business model when we're actually trying to reduce these transports? And did I miss that in the report, or has it come up as an issue?
So I think that's the whole point of these models, right? Is that right now, traditional EMS is paid only for transport, and that creates some incentives and problems in the system that are maybe not the behaviors we want to incentivize right now, right? If this is your question. And so they are trying to innovate around delivering care within their scope of practice that, or with care partners that have larger scopes of practice, but that allow them to meet patient needs in a better way. And as you can see in the report, there are a large number of transports that are probably not emergent, right? So that's a large number of people who are going to EDs in ambulances that don't need to be there. They need some sort of attention. They called 911 for a reason. But that is certainly a place where I think some change, be it how the financial incentives are set up or how hospitals work with their local EMS. I mean, I think there's space for innovation.
Okay. And the last question, you mentioned a couple of times that the activity was grant funded. Funded. Okay. So you got the grant. It works. The grant's over.
Yep.
They stopped doing what works?
That's the problem.
Why would they stop doing what works instead of building it into their practice?
Well, I think that was the point of this study, right? Is that they're seeking a way to get to reimbursement, and we just don't have the data to make the best argument yet. But it looks like things, you know. So I think, you know, we're talking about West Baltimore. Is that working or not working? It's too early to tell, right? These seem to be great programs on their face, but if you're going to make a business case to insure, or you're going to make an argument to DVM about Medicaid funding, you really need to have the data that backs up the budget argument you're making.
Thank you.
Yeah. Commissioner Grady.
Nice segue, because my main thing was this is a bit of a half a loaf without knowing the cost of it.
Right.
You know, if I was on those committees, I'd kind of go, great, you've moved me up the learning curve, but I don't have the tools I need to make it.
That's exactly right.
So I guess on one thing, we do know that the providers of this service have a strong vested interest in seeing reform in this area. So I guess part of what seems to be in the way of being able to come up with even back of the envelope cost estimates is this gap in terms of, especially the people you don't transport, of figuring out, you know, is this a Medicaid, a Medicare, uninsured, whatever.
Yeah.
So I guess and maybe I like Bob's idea of the transmittal letter to say to the committees, you know, if you want us to keep digging at this, you know, a representative sample, ask the drivers, and with all the caveats that they're saying Medicare because the person looks old, and that's about the quality of the data. But that's more than we've got right now. Something of a second follow-up to get them to a point of whether they want to do it, whether they want the cost commission to do it. But somebody has to put a cost on these options to be able to figure out what's going on. The other thing I wondered about, you seem to go easy on the Medicaid guy. You know, having a guy who's worked for decades in reimbursement policy and whatnot, $100 flat fee, I'm sure the budget guys love that. That is really predictable. You can do that. But I can't imagine that it's one size fits all. And I guess I want to ask you on follow-up. When you say kind of the Medicare guys, the feds do it one way, and then the private guys do it, they have more complicated algorithms. Is there a consensus around that? Or is there a massive variety of, you know, United does it this way, Blues do it this way, Medicare does it that way?
So I don't know for sure, but my understanding is that there are several billing codes related to the sort of complexity of the transport.
Yes.
And so the issue is that Medicaid only pays one code.
Medicaid or Medicare?
Medicaid.
And it's a $100 code.
Yeah.
Got it.
And it's about 100. And so the only way you're going to get reimbursed from Medicaid is to submit under that code. If you are, for any of the other insurers, that there's more options for codes and then thus more variation in the payment, but I think it's a standard coding system.
Pretty standard coding system. The codes come from CMS? Yes. Industry representative? Oh, okay. I mean, most things have to do with coverage. I mean, part of the problem is like pediatrics is, you gotta, CMS deals with old people. You know, you got to wait longer than most people if you want a pediatric code, because you get your codes as well as for the Medicare population, you get your reimbursement from them. So to sort of I mean, it sounds like you just sort of said, Medicaid, you might want to take a look at that, where it sounds like there's sort of an industry standard of best practice, or at least a group of algorithms that commonly are used, and $100 a pop is dinosaur. You know, it's just ancient thinking. But you've been very diplomatic and very polite with them. But and it is true, they have zero money, so they are going to take it out of somewhere else. If these guys are going to get paid more the way they would be paid under Medicare or from the generous reimbursement of CareFirst.
So, and I really don't know anything about where they get the cuts from, but one of the things on these other services that starts to look more like home health, I'm willing to bet you the payers are going to say they don't want to pay more than they would pay a home health agency to do the same service, irrespective of the cost to the MS provider. We don't want to pay you based on your cost if we could get the same service from someone else for less.
But that's also why you brought up the idea. I thought very good about thinking. I mean, we have overutilization by people in other areas. We certainly have seen drug plans that sort of go, oh, you know, first three, you know, but if you're really on a chronic disease script and you keep wanting the convenience of, you know, just going down to Walgreens, well, we're going to give you some fairly strong financial incentives to move to mail order because you're costing us a lot of money. And, you know, that's not it. So again, this idea of I'm nervous, my blood glucose looks high on me, I'd like the EMS to run it on their glucometer so they can confirm what I am, you know, and 5 guys have rolled and, you know, driven, you know, 10 miles to do it. You know, so, I mean, to a certain degree, they've avoided all the other kind of structure for years because it's the volunteer fire department. So you don't get paid, we don't tell you how to practice what you're doing. If you want us to pay you, there's rules. So I guess I'm just wondering, Medicaid seems very archaic.
Yeah.
No, anyway.
Very good.
No, I'm with you. Yeah, I'll shut up. I but anyway, 2 things. One, I think we got to get a cost estimate here in the next generation, and they have to be, you know, able to hold up to hard scrutiny. And second, I do think to keep saying that it's okay to pay $100 a pop when you know nobody else does that. They can handle the heat. They're big boys and girls. They're tough.
Director?
So I wanted to remind the commission that the transmittal letter is going to be from both NIMS and HCC. So I think some of the comments we will put in, but I don't want to have a back and forth between the EMS board and HCC. So if what I'd suggest to the commission is to give us some flexibility so we can get this report released in a timely manner. We're already over a month overdue with it, and certainly I think the points to be made that the commissioners have made can be made in the presentation to the committee, but I think it would be unwise to get embroiled with the EMS board on this.
I think that's fine. I think this is just an area of reimbursement that for years has stumbled because it's been, you know, logical arguments, interesting anecdotes, not much real data.
And I think to the point that a couple of you have made, really the $100 was sort of taken as this is what we're going to pay, and this is what we're going to pay. And obviously, you know, not paying even mileage off a fixed rate is kind of bizarre today. But the ambulance the transport services are not rolled into MCO rates. They're paid directly by Medicaid. And one way to sort of develop some efficiency is to roll it into the MCO rate. So the entity that's policing the medical care is also managing the transport benefit.
I will say we didn't discuss that in
None of that
detail.
was discussed. That's just what I just said. So we took that off. They sort of walled some of these issues off on the discussion. So it's not for lack of trying on our part, but rather that Medicaid was rather insistent that this is what we were paying.
Okay. Commissioner Reimer.
The only other comment I want to make, you talk about gathering data on cost. We can certainly get it from the hospitals and emergency room cost. So that's there. So if you can take a look at the number of transports that are being brought in the ERs that were not appropriate, take those dollars right there. It's a fairly large amount of money, and that could be probably be saved a good chunk of that right out of the hospitals. And certainly with the total cost of care model that just went into effect, there's got to be some incentives built into that system to allow them to understand that's probably a good thing not having those costs anymore. So that's just my thought there. But we can get that data. That data is available.
Okay. Thank you very much. Any further questions? All right. In as much as we have got to get this report out,
Yes.
and we have to get it out in a collaborative way,
Yes.
we do not want to enter into extended negotiations with our neighbors to get
Okay.
this done. So, nevertheless, the points, particularly the arguments and the points raised by Dr. Pollack, as well as some of the other issues here, you have heard them all. It may very well be in your presentation, either put it in a slide or maybe a separate letter. It's irrelevant to me how it's done, but they have got to, those observations have got to be communicated
Okay.
to our friends in the state legislature. It'll give them an idea of exactly how complex some of this stuff is.
Yep.
And that's why, in fact, this is really, it's not just the data. There's other issues here with regard to, cross-cutting pressures and unintended consequences that we have to think about, why this has to require a deeper dive than even what we've done so far. Is that satisfactory, Megan?
Absolutely.
Okay, very good. All right.
Mr. Chairman?
Well, yes, Commissioner.
Mr. Chairman, is there a reason that we simply, in a very brief format, can't add in the transmittal letter, the following comments were noted by commissioners of the MHCC in their review of the report, so that it doesn't appear to be attributed to both agencies, just attributed to one.
So I think that's our approach going in, without, a lot of, whether may I request that we would be respectful that it's a joint letter, but these are the comments we heard from the commission. And, it may be that MIMS, as they contemplate this, would agree with this. My main point was, I don't want to delay the report. I think, if that's not acceptable, I think option 2 would be in the presentation or in a separate communication, other issues to be considered. We just send a letter. I'm not saying we sweep any of these.
I think that's
under the rug, but just we don't want to get tied down by what's in the letter necessarily. But I think we start with what we heard from the commissioners. That's always our first step. And I don't think that the issue on Medicaid is really, I think, well put, but we never really, that was, as far as any discussion I had, never raised as a point to consider. So we probably want to discuss that with our partners at Medicaid before we throw that out as being unreasonable.
I think Medicaid first and foremost wanted the same things that a private insurance market company would want, which is they wanted good data that they could use to make a cost estimate. So I think sort of many of the other issues related to network adequacy, issues related to some of the other things we talked about today were sort of secondary.
Right. Okay. I don't think we're going to have any trouble discussing this with them. Okay. All right. Are there any other questions, comments, observations? If not, do I have a motion to release this report? A motion from Commissioner McCarthy, says, and for a second, Commissioner Thomas. Okay. Is there any further discussion on the motion? If not, all those in favor of a motion to release the report, say aye. And
aye.
Opposed? Good. No, non-opposed, right? Got it. Thank you. Thank you, Megan. Our next item is a report on an update on legislative health IT work groups. We're going to receive updates from the staff on 3 health IT work groups that were initiated during the 2018 legislative session. The chair of the Senate Finance Committee asked the commission to identify deficiencies in existing policies related to school-based telehealth programs and develop an approach to improve those policies. Eva Lenore and program manager in the Center for Health Information Technology and Innovative Care Delivery will provide an update on the school-based telehealth work group. Nikki Majewski, is that properly pronounced? Majewski or Majewski? Majewski, gotcha, okay. Chief Health Information Technology, Chief of Health Information Technology, will give us an update on the electronic prescription record system work group, which the commission staff convened. The law requires the commission to assess the benefits and feasibility of developing a statewide repository of non-controlled dangerous substance for prescribers and dispensers to access patient medication history, correct? Ms. Majewski will also provide an update on the Health Record and Payment Integration Advisory Committee that the commission convened under Senate Bill 896. The law requires the commission to assess the feasibility of creating a health record and payment integration program. These work groups are due to report to the commission late next fall. Our responsibility is to report a study finding on all these issues and report to the General Assembly in December of 2019. So there's time, plenty of time, but we have to start. So I guess Eva, you're number one, right?
That's right.
Okay. Floor is yours.
Thank you. Good afternoon, commissioners, and thank you for the introduction. So as mentioned, today we'll be providing some information on legislative work groups the Center for Health IT is conducting, including some background, the approach that we're using, where we are in the process, and what we hope to accomplish this year in 2019. So as mentioned, we'll be describing the three work groups that were charged to the Maryland Healthcare Commission following last year's legislative session. So we've taken a similar approach in convening the three work groups. We are conducting broad outreach to ensure a balanced perspective among all our work group members. Charters were developed to guide the work group and define its responsibilities. And the work groups are using information gathering grids to identify benefits, barriers, and potential solutions related to key discussion items and in order to guide work group deliberations. So first we'll be discussing the school-based telehealth work group. So as mentioned, it was formed in response as a request to the Senate Finance Committee that expressed some concerns about the slow pace of development of school-based telehealth programs in primary and secondary schools in the state. The work group was charged with identifying potential deficiencies in current policies related to school-based telehealth programs and provide proposed recommendations based on the work group's findings. The work group met 7 times in 2018. Initial meetings were used to build awareness among work group members of the current landscape of telehealth programs in the state. There were presentations provided by various state agencies and public schools, including the Maryland Department of Health, the Maryland State Department of Education, the Maryland Community Health Resources Commission, and Howard County Public Schools. And so this approach helps to ensure that work group members had a basic understanding of the landscape of telehealth and healthcare delivery in a school-based setting in Maryland. And an interim report was prepared, and as mentioned, there will be a final report due in November. So the interim report represents a compilation of work group activities that took place during 2018. It describes the tasks and the approach taken to foster engagement across stakeholders, and contains a summary of current school-based telehealth landscape in Maryland and the nation, including descriptions of various roles, types of services offered, and opportunities for greater diffusion of telehealth. The report also highlights key themes that have emerged from work group deliberations so far, and next steps to be accomplished in 2019. So in exploring school-based telehealth, the work group focused on 8 policy areas centered on implementation and raising awareness of telehealth, technology and management of processes, existing compliance requirements, and funding for implementation and sustainability. So the work group used the information gathering grid to identify benefits, barriers, and solutions related to each key policy area. Several key themes are emerging based on discussions so far, and these will continue to be deliberated on in the future. They include, but are not limited to, establishing a flexible telehealth adoption pathway that fosters alternative approaches to using technology, engaging parents and guardians through outreach and education activities, promoting continuity of care by connecting community providers and students' medical homes, and ensuring that programs are compliant with established privacy and security laws. So as work of deliberations continue over the next 6 months or so, we plan to spend the next 2 meetings finalizing the key themes and drafting proposed recommendations. And we will be vetting these with stakeholders in the spring. And we plan to present these recommendations to the Commission at the September meeting. Great. Thanks, Taylor. So I'm moving on to the Electronic Prescription Record Systems Work Group. Following after House Bill 115 was passed last session, we convened a work group of interested stakeholders to assess feasibility of developing a repository for non-controlled dangerous substances. We first convened in July and was met about monthly over 2018. A final report is due at the early part of next year in January 2020. So similar to the telehealth report, we're going to provide, that is currently being drafted, we'll provide an overview of the current landscape as it relates to PDMPs in Maryland and the nation, as well as some emerging key themes from work group discussions. And this report is targeted for release in February. In terms of the key themes that have emerged so far, there's sort of been general consensus that sort of addresses the why are we doing this study about how access to complete patient medication history can enable providers to provide more efficient and safer care. There's also been discussion about the need for a mandate and how that could be supported by a phased-in implementation plan with potential pilots among different pharmacies and providers possibly. There's also been discussion about support for balancing the need for patient safety with patient privacy. And there's been some discussion of an opt-out approach, which the work group has expressed sort of consumer education being paramount to sort of at the point of care explaining the benefits of having your information available and any sort of opt-out tech option if one is available. Regarding next steps, we're planning to continue our deliberations over the next 6 months, and it's anticipated that we will have a final draft of key themes and potential recommendations for vetting by the work group and stakeholders across the state. And these a presentation with our findings and proposed recommendations is targeted for later this year.
So I think on this one actually has some good momentum behind it, but it's not worth. But it does face some challenges. Why are we doing this? And we all go to the doctor, and it seems like they have they're reconciling medication histories before you can literally get into your chair. And the reality is that yes, the prescribing physicians and if shared with others, medication histories are available, but there is a data feed that flows from pharmacies to payers and is intercepted by the prescription drug monitoring system for monitoring CVS drugs today. There are a number of vendors that are involved in this data interchange, largely private firms. And the thinking was that this works well for CVS drugs. Why not use the same sort of mechanism to intercept the non-CVS drugs, route it through, potentially through CRISP, and make it available to treating clinicians, not only the prescribers, but those that may see a patient on a new basis or emergency basis. They too would have access to this prescription history, that would be very helpful. This data stream is valuable for another reason too, in that it captures actual drug fills. Dr. O'Connor may order a drug to a patient, but the patient dutifully says, yes, I took it, but you have no way of confirming that. With this data feed that's coming from the pharmacies, they can actually see whether it's been filled. So it's helpful to judge compliance as well. When we got started with this piece of legislation last year, the Medical Society and others raised concerns that it was too fast, too soon, and thus the work group was kicked off. The privacy folks in particular were very concerned about taking a data flow that was used originally for controlled substances and applying it to the broad spectrum of all drugs used. And so I think Nikki and David have worked really hard to break down some of the challenges. We are making progress, and we expect a set of recommendations that will reflect the compromises that are going to be necessary to make this work. Did I miss anything, or am I inherently wrong on anything?
No, that's fair. And in the interim report, we're going to share some of that background about how this sort of ended up as a study bill.
Okay. Any further questions?
Okay.
Oh, that's right. You do have one more.
One last work group or advisory committee. This is for the Senate Bill 896, and this Health Record and Payment Integration Advisory Committee consists of various stakeholders required in law, and they're tasked with assessing feasibility of incorporating, among other things, claims into the state designated HIE. We had a kickoff meeting as well in July and have met about monthly, and a final report is due later this year in November. So similarly, that report will also talk about the current landscape as it relates to the health IT infrastructure in Maryland and nationally, emerging key themes, and this is targeted for release next month. So in terms of the key themes that have been identified so far, in general, these themes have focused mostly on need to address many policy funding and technical complexities to support sort of a consolidated infrastructure. Discussion of a mandate to connect 32 clearinghouses would require more in-depth technical and a financial assessment in terms of how that would be embraced by the industry as well. The clean claims requirements in the Maryland Insurance article and COMAR, based on deliberations, there does not pose any significant challenges to providers at this time. These are sort of where the discussions have mainly focused, and we'll be using these key themes to sort of guide how we draft potential recommendations. So I guess next steps that will happen over the next 3 months, and this informal draft of key themes and recommendations will be vetted with stakeholders, and we plan to bring a presentation back to you with the proposed recommendations by June this year.
All right. Okay, now, are there any questions at all? O'Grady, you have nothing to say? Have the record show that Commissioner O'Grady had nothing to say. No, I wouldn't dare. Yes, Director.
On the school-based telehealth, this too has been a project that the team here has really had to navigate a number of competing constituencies between the Department of Health and the Department of Education, and competing approaches between school-based clinics, which are permitted to deliver services through telehealth today, and school-based health services that currently, and tell me if I'm wrong, are not able to do that. And each of them has their little fiefdom leadership at MGH has really encouraged us to try to work through these challenges on the belief that providing some additional clarity on when telehealth services could be delivered would be beneficial to the public, even though bureaucracies have their stakes in the ground on these issues and have good reasons in many cases for why they think this should go this way and not that way. But staff is doing a really good job on balancing all these priorities as we move forward. So.
Okay. Anything else? Ladies, thank you very much. Thank you very, very much. Okay, our next item has to do with the legislative process for this year. They're off. 2019 legislative session is already underway. This year is the first year of Governor Hogan's second term, and we expect to see significant changes in the committee leadership in the Senate and the House. The commission makes advice, renders advice and counsel on legislation, giving the staff direction on policy for the legislative session. So what we do and what we do not do in this area is going to be very important this year. Megan will come to us again and provide an overview of the 2019 legislative session and describe the review process, right?
I'm going to, yes.
Okay, let's tell us how it's done, Megan.
I'm going to tell you how it's done, but also say this is my first year, but for many of you, it is not your first year.
Oh,
so also, you can tell me how it's done. Should I get anything wrong or you feel like there's more to say, please feel free to jump in. So the session has started. They started last Wednesday, and Governor Hogan's inauguration was yesterday.
That's right.
So all the big ceremonial stuff is over, and they're getting down to the real work. So today I'm going to talk generally about the session, and then focus on the role that executive branch agencies, including our commission, play, and your role as commissioners. So first of all, just a sense of what the presentation will cover. I'm going to talk about dates of interest, the overview, key leaders, and then talk about your roles. So turning to dates of interest, as I said, the inauguration was yesterday. Tomorrow we should see the budget bill if we don't see it this afternoon. So that's a big day. And then the final day for introduction of administration bills without rules consideration is on the 21st. And then as we look ahead, March 4th is the final day for introduction of bills without suspension of the rules. And then March 18th is the crossover date, which means those first few weeks of March are very busy times in the legislature. And then it all comes to an end on April 8th. So this is a very fast moving 90 days. So what about our dates of interest? I suspect there will be more as we move forward, but here's what I have today. Today was a big day for us. We had a briefing in front of HGO this morning, just an overview of the commission. Ben handled that very well, as given his extensive experience, not surprised. And then David Sharp is in front of finance, or hopefully done by now, but to talk about the school-based telehealth work that you were just briefed on. In early February, we'll go back to HGO to talk about certificate of need in our report. This is sort of the parallel to a briefing we did in front of finance in December. And then we have some budget hearings also in early mid-February. So here's just a sense of the General Assembly. I think, and pointing out the committees that most impact our work: finance on the Senate side and Health and Government Affairs on the House side. Our label's got a little messed up there, but when we switched to columns, so sorry, ignore that policy and budget in parentheses. That doesn't belong. But what's important here is that there has been 30% turnover this year in the legislature. There are huge numbers of new members. And then I am excited about the fact that there's a record number of women. With respect to leadership, we're also seeing a fair amount of leadership change. So the chair of the Finance Committee changed, as did the vice chair. The chair of the Budget and Taxation Committee changed, as did the vice chair. And we also see change in Education, Health, and Environmental Affairs, although in that case, it was the vice chair moving up to the chair role. And that's on the Senate side. On the House side, Chairman Pendergrass is still there, but Delegate Penna Melnick has moved into the vice chair role, and I know she's been an advocate for some of our things in the past. And they've had some change on the subcommittee chair space, and there's no change in appropriations. So what about our role? Our role is to educate legislatures about MHCC and what we do and build relationships for the future. That is always our role. We can suggest legislation. So, for example, we had recommendations related to statutory changes in the CON modernization report, either for this year or next year. And then providing support for our MHCC budget request. Bridget handles a lot of that work for us. And then we review bills that come before the legislature to see if they're relevant to our statutory purpose and our operational needs, and then share a position if we have one. And then we provide information in areas of expertise that is helpful to the legislature. So, for example, I got a request yesterday about a report we've done on the March report we did on private insurance cost and utilization. So somebody was asking about prescription drug costs. And so it's our job to provide that information. And what's your role? So what we ask you to do during this session is when we have a bill that staff recommends we take a position on, we will provide you with that recommendation, and then we have a policy call in which we get your feedback about whether that's the right position to take. And so I'm looking to set that up as a weekly hold. That doesn't mean we'll hold the call weekly. If we don't need your time, we're not going to take it. But I sent out a doodle poll, or Ben sent it to you, but there's a doodle poll out. If you could please fill that out by tomorrow about whether you want Friday morning calls or Monday morning calls. That will help me determine whether they're on Friday mornings or Monday mornings. And we'll start in a little over a week with the hold, but also communicate clearly about when we're having the meeting and when we're not. All right. And then our job, again, is to review bills that are related to our priorities or our statutory responsibilities, or where we have precedent on working on the issue. And then our role is to either provide letters of information, letters of concern, with support with amendments. There's some options. We'll get to that when we're in the meetings and have the calls. But there's sort of a set of options we can take with respect to what positions we take. And then the next is just a flow chart about how position papers get developed. So starting with staff, and then review within, again, at the staff level, but with legal review, and then going to the executive director and then to all of you before we share it with our colleagues in the executive branch, and then with legislatures. In general, we're encouraged to take, well, there are three kinds of legislation I'm going to discuss that are sort of, if you look at it from the governor's view, how does he think about things from a priority perspective, and how does that change how he treats legislation? So there's administrative legislation that is their highest priorities. They come directly from the governor and the lieutenant governor. Generally, they would look to their agencies to support that legislation or not get out in front of it and trip them up. So, so that's one category. And then there's departmental legislation that comes from the departments. I go to a weekly meeting at MDH on Friday mornings in which we talk about positions that different entities within or related to MDH are planning on taking with respect to legislation. The goal of that meeting being that we don't conflict with each other in public. So we're trying to all be aligned. And then the governor's office has a meeting on Monday to solve any discrepancies that weren't solved at a department level. And then there's privately sponsored legislation, so it's not coming out of an executive agency or the governor's office. And there, if we're supportive of privately sponsored legislation, again, we just want to coordinate with the department on positions so that we're not conflicting. That's something we discuss on Friday mornings. And then finally, I'm going to talk about the budget. That's just an overview of the process. So it'll be introduced by the governor today or tomorrow. And then budget hearings go on throughout the session, but ours are in early February. And then after the subcommittee hearings, it'll go through full committee, chamber, and conference. And that has to pass by the 1st of April. And that's all I have. So I want your questions, comments, feedback. And then just a reminder, if you have not filled out that doodle poll, please do so.
Thank you very much, Megan.
Yeah.
Okay. Any questions?
All right.
Yes.
Oh.
Commissioner Brady, you put up. No. No. Oh, very nice. Okay, very good. You didn't raise your hand, Commissioner Tamarchio. It was just you were brushing your hair. I'm observant, you know. Okay. Thank you, Megan. All right. Okay. Next presentation is on the Commission's strategic priorities. Every 4 years, the Commission identifies its strategic priorities after consideration of what the healthcare needs of the state are and policy objectives of the governor. This year, the Commission and the staff worked collaboratively on 5 priorities that are aligned with the Commission's mission, its capabilities, and its regulatory authority. We're in a very, very exciting time. There's a lot of things going on in healthcare. It's a very, very challenging period of transition. Part of that for us is that we are transitioning into the total cost of care model this month. The total cost of care model will require some very significant changes in care delivery, and our priorities reflect a commitment to make sure that the model works as well as it possibly can, and to make sure that we get improvements in the financing and care for our fellow citizens. I've asked Ben to review the strategic priorities, and I encourage you to see this presentation as an opportunity to talk among yourselves about how we can best move things along. Ben?
So the original plan, I still want Paul to come up. Okay. The original plan was to have the center directors all up here, but we have 2 that are absent. So I'll just ask Paul, since he's up next, to join us at the table without reflecting that the other center directors at this point would possibly have something to add, but also recognizing it's maybe a little late in the day.
Sure.
And we want to get to the last
Right.
presentation.
Sure.
I'll ask Paul to operate the slide, and perhaps if there's commentary, we can engage him or Ken in that discussion. So you have before you the strategic priority report. A little bit about this. I know most of you were at the Commission retreat in November after the November meeting. The ideas were, the priorities were developed and presented and discussed discussed at that meeting. Then the staff went back into action, worked with our retreat coordinator, facilitator, Discern Health, to develop the report. It went through several iterations. An early draft was shared with the chair, and you have all received the draft report early this week. I think it's a good reflection of where we are, where we want to go. And I'll first begin by talking about our roles, which I think today you've seen a tour de force on the roles that the Healthcare Commission holds in the state of Maryland. We're a convener, a witness to work on work groups. We measure and aggregate quality data. We saw that in Courtney's work. We enable information technology innovation. We assess policy options. And of course, we plan for health facility development. Those are what we consider our roles. They don't necessarily represent action on our part, priorities, if you will. Those are what we can take on. I want to step back and remind everyone that in 2015, we did a similar report, just touching on, we had 4, so I wouldn't yet claim that we did so well. We added a 5th in 2019, but sure looks that way to me. We had 4 priorities: expanding public reporting of health system information to drive transparency. And we had some, what I would consider some important milestones there. Some would call it successes. And we aim with in that general vein to continue the focus on quality and cost, making in 2019 and maybe a little more ambitious claims. We also focused on elevating primary care. We had at that point a advanced primary care program called the Maryland Multi-Payer Program. That program did demonstrate the success, the feasibility of having an advanced primary care initiative. We continue to advise the department on the rollout of a larger model, but we also believe we can expand our support not only to primary care but to specialists going forward. And to that end, we've had a number of successes. The Practice Transformation Network that Megan and David are leading is one example of taking a program that primarily focused on primary care providers, but aims to engage other practices as well as one transitional initiative that will take us from where we were with primary care in 2015 to the priority in 2019, which is focusing more broad on engaging all types of providers, not only healthcare practitioners, but other healthcare providers, including nursing homes and potentially home health agencies as well. We focused on modernizing health planning to address the capacity needs under the new all-payer model in 2019. I think we did a pretty good job here, but we didn't necessarily do the job that we set out to do in 2015. The legislature and other healthcare delivery challenges got in the way. We did make a number of changes. The most notable is in the home health state health plan that we adopted in 2016 that allowed for greater consumer choice. But we also spent considerable time developing a framework for hospitals to transition to freestanding medical facilities, what I like to say ambulatory hospital campuses, which included a suite, as envisioned, a suite of services, but not inpatient care. We did a job of taking something that was conceived of by the Hospital Association, working with the legislature to a program that was more balanced, allowing commission public input, and actually have implemented that model with the conversion of the Laurel Regional Hospital to and FMF, with 2 more on their way. And then most recently, we provided greater flexibility for HMOs to provide services in the state. It was focused on initially on ambulatory surgery services, but I think that was an important step forward in streamlining CON and removing from CON authority a type of service that didn't need to be subject to that structure. And lastly, lest you forget, we had a number of important initiatives in HIT, health information technology, to maximize the use of information. If you benchmark where we were in 2015 to where we are in 2019 with EHR adoption, there's still work to do, but we've made good progress. We've also brought in other methodologies and approaches, including our work with advanced directives and maybe most importantly, working with Chris to not only encourage them to do more, but developing mechanisms to measure their progress going forward. When you award a monopoly to an entity, I think it is warranted to also carefully peg and measure performance. CRISP is widely lauded, appropriately so, but we can't forget that we are squeezing out some initiatives that might otherwise take root here because we are putting so much investment in CRISP, and our intent was to measure their progress, and we are a long ways on that way. Stepping back, in the report itself, it does remind readers that we have made progress, but there's a lot of work to do. And I thought, for purposes of comparison here, that the Commonwealth Fund state scorecard is shown on the left. The United Health Foundation state scorecard, which is not in the report, is shown on the right. I did provide more detailed results for you all in an email communication earlier this week. What's sort of remarkable, I think, is how close they are in terms of the overall aggregate scores, keeping in mind that actually the underlying metrics are not necessarily all the same. And what's also somewhat remarkable, I think, is, one data point is one data point. Commissioner O'Grady would say we've got to be careful here, but we fall about middle of the range in terms of state performance, and maybe a little bit of concern is that we fell to state positions since 2017 when it was last reported. So although we're proud and tout our performance, I think more importantly than criticize us necessarily, I would say that other states are moving forward with initiatives that show progress as well. Turning then to the priorities for 2019 and 2023, and I say that, but leave open the opportunity to say that as we move through that time period, it is likely that we will certainly refine the priorities we've laid out today, but would also possibly add others or determine that one of the priorities we're selecting is no longer necessary or exactly on point to what we need to do, given the roles that the commission has. We have 5. The first is to educate and inform and engage the healthcare community. Consistent with that, first off, we're organizing a much more focused group here at the Healthcare Commission under Megan's direction. We're bringing the communication plan of each of the centers together so we can focus that in a more efficient and effective way. Not that we haven't made progress, but I think MHCC overall strategy is necessary. We are going to develop a strategic plan. We will also focus on the redesign of the MHCC website, improve, take advantage, greater use of social media, and most importantly, to improve communication with our stakeholders in general, but in particular to the consumers. In particular, clearly with the new total cost of care model, there are new requirements and obligations that are expected of consumers. I think they are ill prepared for taking on, or certainly unaware of the expectations of what they need to do. And I think the MHCC alone can't do this, but in concert with others, we can make a major contribution. The next priority is to make the Commission a trusted source of quality and cost information. We already do that, but in the last several years, we've taken a much more pointed view on transparency, price transparency in particular, with a recognition that price always has a quality component to it, and arguing that our perspective is that prices could be lower, prices should be lower. We debated that for a while, and both are true, and the awareness of the public of these variations in price are necessary, but not necessarily a sufficient condition to making all that happen. But we have to engage consumers in a more effective way, and we have to take a perspective on what we think about costs in the state of Maryland. We are going to build on an initiative that was launched by the Board of Internal Medicine, their Choosing Wisely project that was launched 6 or 7 years ago, in which they asked specialists to identify low-value services. We'll build on that by working with provider organizations to help define and identify among those listed nationally services in Maryland that constitute low-value care. We made a fledgling effort through our work with MedChi in developing a video on appropriate use of advanced imaging for low back pain, and we'd like to expand on those approaches moving forward. Probably not getting into the video business in this domain, but really working with the association in ways in which we can showcase services that develop or generate little yields for the cost of those services. Incidentally, this particular issue generated a lot of questions from legislators this morning and a lot of interest on their part. And lastly, in this domain, we've been talking about developing an outpatient surgery comparison tool. The data issues are challenging, but we're ready to begin to develop that over the next 9 months with the aim of rolling out in a limited way comparative information on both the cost and quality between ambulatory surgery centers and hospital outpatient departments. The third priority is one that is really transferred from the last 4 years, but represents, I think, a further refinement and precision on what we aim to do. We now have a clear idea of how we need to modify CON to help implement the objectives of the total cost of care model. We want to provide, through the state health plans that we will be revising, opportunities for innovators that are committed to values that we hold dear: quality, high quality, affordability, safety, to have an opportunity to enter the Maryland market. And for those both new practitioners of field, those new applicants and existing organizations, we aim to reduce the burden of CON regulations to limit state health plan standards and review criteria for those that are meaningful and necessary to make a judgment on a project. Building off of our efforts on primary care, we intend to engage a broad swath of providers in educating them on how they might participate in value-based models. We are going to launch a number of transformation initiatives to help prepare practices to participate, consistent with what we've learned through the Practice Transformation Network, the PTN, that we've done under support from CMMI over the last couple of years. We're also planning to partner with HSCRC and others to expand the opportunities for hospitals to participate with hospitals and other providers. Currently, as you know, the fact that we have a strange healthcare, a Medicare system that deals with reimbursement under Medicare Part A and Medicare Part B, and the funds between them cannot be switched, has limited the types of innovations that we can introduce. That is a challenge, but that is an effort that I think is going to generate significant benefit if we can overcome some of those hurdles. CMMI has been very helpful with issuance of waivers, but it's safe to say that today in Maryland, the healthcare reform is largely led, hospital-led, and if it is to be as effective as we hope, we have to more effectively engage other categories of providers and payers as well to make it as effective and high value as possible. And lastly, as long as we are dealing with the Medicare, the macro reforms of 2015, we think there are roles for the Commission to play in convening provider groups on how to take advantage of that. There are, of course, rumors afoot that this may be significantly modified. Should that come to play, I think we're well positioned to respond and develop programs that will take advantage of new incentives that might be put in place by the federal government. And lastly, moving from simply a broad focus on health IT, our focus now is more targeted at promoting and elevating the use of telehealth. It's not without its technical challenges, which we can address in a limited way, but we can play a major role in education on how to take advantage of it. Next month, you'll actually hear a presentation from the Commission staff and Research Triangle Institute on a telehealth readiness tool. Tell me that's so, Alana. And it's just one example of us trying to allow providers to assess whether they're ready. We'll focus on increasing, identifying policy that can help diffuse telehealth. This morning I was asked what it was. Sitting next to the Secretary of Health, I did volunteer that some changes in Medicaid reimbursement policies to allow greater use of telehealth might be desirable. Notwithstanding the discussion you had with Megan earlier about challenges and reluctance of Medicaid to do anything that would change or increase reimbursement, I think they have to focus on this. But we'll also be looking at medical liability law, and certainly some of our friends at MedMutual, the largest medical liability insurer in the state, tell us that practices and approaches to assessing liability for providers to opt to deliver telehealth are not necessarily where they need to be. We'll also be working with our boards to figure out what needs to be changed to facilitate the interstate delivery of telehealth services, which I think would also open opportunities for us to export telehealth services. Both of these large health systems, academic health systems, have postulated that they have a 50-state telehealth strategy. Certainly, they may have a strategy, but affecting one may be a bit more challenging. And working with our colleagues in other states, I think we can do more to understand what limitations there are elsewhere. We'll also work on the implementation. We have launched a number of grants and we continue to do that. But the focus will also be on taking some of these models that have been productive, promising to scale moving forward to broader implementation. Those are the 5 priorities. I hope we can have a little discussion. But before we leave this, I think that I want to reflect the widespread perspective of the commissioners in the retreat, that the commission needed to have a strong commitment to working with others to reduce, use the word here, to reduce the disparities in social determinants of health, which go beyond what typically healthcare providers think is their role. Although we can point to some success factors here in Maryland, we do a good job compared to other countries in managing acute illnesses, but we struggle in particular with chronic conditions, and social determinants play a major role in the prevalence of obesity, heart disease, diabetes, and others. And these are certainly outside of the range of what the commission does. We're not going to be fostering expanded educational opportunities, employment, etc. But we need to be aware of how those opportunities or the lack of them affect the ability to access the healthcare system. What we actually ought to be doing and thinking about, I think that's a greater discussion for the commission because it means more collaboration with others that typically we don't often engage in. And even as we attack these disparities in the social determinants, we also have to keep in mind that we have always been focused on what public policy can do. Certainly, some people group that as a social determinant. I think it's a determinant, but maybe not a social determinant. But other determinants such as individual behaviors and choices, and certainly as we understand more about our genetic makeup, we all have slightly different genetic risk factors for this disease or that plays a role. But clearly, the United States has not focused as much on the social determinants of health as some of the European countries. Some would see that as a negative, others would argue it's positive. But you can see that when you look at social spending across the OECD countries, that many of you have looked at, that although we spend more on healthcare, when you lump healthcare in with overall spending on social services, we really pretty much fall in line with a lot of the other European countries. And certainly, but the question is, if there was a better balance, would we need to be spending 17.5 to 18, soon to be 19% on healthcare, of our GDP on healthcare? And with that, I'll pause and let Chairman Moffitt comment.
No, I don't have too many comments on that. I think that the social determinants, as I said earlier, certainly they affect medicine, but you can't medicalize all your social problems, all right? So it's a multi-layered issue here. Private investment, job creation, policies that promote economic growth, educational opportunities, all of these things will improve social conditions and therefore improve the social determinants of health. But looking at the literature, I did look at the literature pretty closely, actually over the past 3 weeks, looking at some professional literature on comparative performance between the United States and OECD countries. You're quite right. We spend, social spending in America is just not very different from some of the Western democracies. Some people have this idea that somehow or other they are much more robust in social spending than we are, and that's actually not true. The reality is, we're basically spending what they do in the same neighborhood. Where we have the highest source from the data shows that among the 11 OECD countries studied, the United States simply has the highest rate of obesity, far and away, of anybody. That is really, and you all know because you're in health policy, you know that obesity is directly related to all kinds of not social problems, but medical problems, including diabetes and heart disease and various types of cancers and so on. I don't know how you get people to stop eating saturated fat at the rate which they do, but we really consume a lot. And, I remember going back to my college days, I remember, the family doctor saying, Dr. O'Connor, you might have a comment on this, that most Americans dig their graves with their knives and forks. And that seems to be the case. Our drinking is not out of line compared to the rest of Europe. We drink about just as much as they do, not a lot more. I don't know about that. I'm not sure. Yeah, well, now that we're legalizing marijuana, we can catch up, But, a lot of these things do not lend themselves. I think, my only caution, my only comment on all this is that a lot of this stuff does not lend itself to any kind of specific concrete policy. It does require, actually, and this is the hard part, it requires a lot of cultural change and communication from people who are in a position to actually communicate. And that, in my view, is, a family doctor, probably one of your best sources of communication. The problem is people have to be compliant, and that's another problem. The doctor tells them over and over and over again, try to keep it down to just 2 6-packs a night. They won't do it. Right, Dr. O'Connor? That's a problem. How do you get people to behave? I don't know. We're not going to set up a totalitarian state and ration food that is standardized. We're not going to do that. So we've got to figure out how to deal with these things in a way that's compatible with free society. It's even tougher. Commissioner Thomas.
So just very briefly, I'm actually very pleased that the commission has addressed this social determinants. I think for us, it helps give context and it helps give, how we interpret the data. So I think we should pay attention to the language that we use, like frequent flyers, that at the end of the day kind of puts the onus on the patient. May well be something in the social context of the neighborhood, the policies that prevent that person from not being a frequent flyer. So some of our language, particularly on these lifestyle issues, could end up blaming the individual as if they're not in the context of an environment actually promoting the very negative behaviors we're talking about. So just having it in front of us, I think, can help us ensure that we're not marginalizing groups simply because of their disease status.
A couple of thoughts. In terms of thinking social determinants, certainly we can see that it is becoming a consensus way of looking at things. Certainly the Robert Wood Johnson Big Culture of Health, which is an attempt to operationalize this in some sense. I think that we want to be a little careful to not bite off more than we can chew. But I think that we have, by our other actions, we've already taken the step to start to link some of these things. And I think we know that bureaucratically, politically, policy, our spending access is siloed tremendously. But we've already opened this front with education. That seems to me, if we wanted to say something realistic, certainly as a global sort of thing, social determinants, I like it. But, what's going to be the first beach we're going to storm? What is that first step we take? And I think by our current, we're already at education. That doesn't eliminate doing other things as well. But the same way that Robert Wood Johnson, their first is housing. So you got to start someplace. The other thing that they do that I'd like to see us do is that part of this is access, part of it is opportunity. And so they have a whole kind of dimension there about equity. And to Commissioner Thomas's point, at some point we can't parse out, I mean, it's like what we do constitutionally. We don't guarantee equality of outcome. We guarantee equality of opportunity. And that some of the problems we have here where we find disparities, et cetera, some of it is going to be because there's not an opportunity. And that that if you have something where two people are being offered the same thing and one decides to have the third six-pack and the other one decides to cut it to one, that's not the government to really say, except the government does end up spending more on one than the other. But anyway, I guess I'd like to see this come down a little bit from the 60,000 foot and say, okay, what is our first front we're going to take in there? And I'd also like to add as a kind of it hits in all of them, I think, this notion of equity. Equity in terms of just opportunity, who has, we've seen this come through. Well, what do you do in MPG County? Well, what are you doing in the Appalachian County? The whole state isn't Montgomery. It does not. I mean, however you want to think about it. And we know some of this reflects certainly economic, some of it reflects political power in the state. But as a neutral third party here, I think that there's a lot we could do to sort of point out some of these things, where we see these kind of access problems coming up, where we see these sort of things. And, if you'd like to start taking a bite into this apple of social determinants, we already have a foot in the door with all this school-based stuff you're talking about, and why wouldn't we continue to build on that?
And just follow up briefly, Senator Shirley Nathan Pulliam in the last legislative session passed a law signed by the governor, the Health and All Policy Initiative. So that's been going on now for a while, where all these agency heads are around one table looking at the intersection of what they do and how it impacts health. That group's report might be of some added value to us.
If you don't mind. It might be, but one of the things I've seen in the other work that I've seen is to a certain degree, if I'm running, an employment agency, or I'm running, I'm head of state Department of Transportation, health guys coming in and going, your priority should be health. I got to tell you, that's not going to close a lot of deals. To a certain degree, their priority is transportation or employment or whatever. It is that building these relationships where you find that common ground that you will. So that's why I think in some of the education stuff, that's maybe a first battle to take on, because you know that if you can you can go to an education guy and say, if you can fix your absenteeism, if you can fix your obesity problem, you will. I know the governor expects you to do X, Y, and Z in terms of, whatever, higher education or K through 12. You're not just expecting them to take on your priorities. You're bringing something to the table that matches their priorities as well. And I think until we get to what that looks like, it's hard to think of why all these other silos would. You're just too. Your health is not their problem. Transportation, employment, these are their problem. So I think we just have to be realistic about how we approach these folks.
That's one of the reasons why we wanted to have this conversation. And off the top of your head, basically from what you've read, do you have any observations that can help the executive director and the team here? Yes. Yeah. Now, I think getting concrete is what we have to do. Talking about the social determinants of health without a concrete plan doesn't help us very much. And it's got to be something that is within our capacity. We have to have the skills and ability to actually do something. I think, frankly, we have made a real contribution in one area, which is, frankly, education. We are doing a good job. I mean, we're not doing as good a job as we could. We still have a long way to go. But even the idea of communicating through movie theaters about the importance of being able to get information on quality care is a real step in the right direction. We have a lot more to do in this area.
So what I've heard, is yet another commissioner subgroup. I think what Commissioner O'Grady articulated was, if we can talk about it a lot, but if we want to have an impact, we have to be much more narrowly focused. And the staff will discuss this further, and I think having a longer conversation with commissioners that want to discuss this might be an important first step. We put this out because it did generate considerable conversation at the retreat. I think my thought is that the context in which we work is a broader context than healthcare, to the point that both Chair Moffitt and Commissioner O'Grady made. It's not the role of healthcare to solve the education problems necessarily, or in healthcare, health providers would say, I trained to be a doctor, not to solve housing issues. But how we work with housing experts, I think, becomes a question, or how we work with the education community becomes a question. If you really want to move those folks, you need to engage and work with them, not to tell them that health is their responsibility, but to develop an understanding on both groups' part on the interplay between different categories of social service. So we expect to hear more, and we likely will have some additional meetings with the coalition of willing commissioners that want to talk more about this and think how we could activate an initiative that fits broadly within the priorities. What we plan to do with the report is that it does become a communication document for not only the staff, but a way in which we can educate legislators and other policymakers of our priorities in a very succinct manner. I found the report last, when we used up until really 2018, did succinctly describe what we were planning to do, and we intend to use the report in that way as well moving forward.
Any other comments, observations? Thank you very much, Ben. Let's move on to the state health plan priorities. The commission submitted its final report on the modernization of the Maryland Certificate of Need program to the Health and Government Operations Committee and the Senate Finance Committee last month. You've all read the report. You contributed to the discussion on the report. If you'll recall, that report grouped sets of reforms into three categories: those that require regulatory change, those that require statutory change, and those that require collaboration with sister agencies before adoption. Certainly that's going to be a more challenging task. This presentation will focus on the first group of reforms that can be achieved through regulatory changes. And we've asked Paul to present the staff recommendations on the priorities for the redevelopment of our regulations on certificate of need, and offer some ideas about how to structure that redevelopment. Paul?
Thank you, Dr. Moffitt, members of the commission. I'm very pleased to be making the last presentation this afternoon.
So are we.
You're all very fresh at this point. We're not going to provide anything resembling a comprehensive plan for implementing the recommendations of the modernization report. We want to really kind of start a dialogue here on one aspect of that report, which is updating our state health plan regulations, which are the regulations that provide guidance to the staff and the commission on the review of the projects that we're required to authorize under the CLN program. And then I'm going to briefly also touch on a very important set of regulations, which are not the state health plan per se, but are clearly very important, the procedural regulations, and the report included a lot of recommendations with respect to those as well. So in the report, we had a recommendation that we wanted to identify the state health plan chapters, and we call these state health plan regulations for specific project categories chapters. What chapters are most in need of updating and offer the greatest potential to meet reform objectives, and then prioritize our approach to revising that state health plan. And the report also provided some guidance on how we want to redevelop and reorient the state health plan. We want to look for a more limited set of standards in each chapter of regulation, and look for ways in which we can simplify those chapters, not only to eliminate some of the administrative burden on the regulated industry that has to prepare these applications and address our state health plan regulations, but also to kind of simplify the entire process of reviewing projects as well. So what we're really looking to as kind of the key aspects of state health plan regulations going forward are project need, project viability, the impact of projects, and here we're primarily focused on the impact on cost and charges, and on access to care, and on applicant qualification. And this latter one is reflects a direction that we have been going in recent updates to the state health plan, specifically in home health care, where we actually create some thresholds based on quality measures for becoming eligible as an applicant in Maryland. This is also an area that we're going to be talking about in the near future, because we're talking about possibly taking a similar approach in our nursing home standards update. So this is just a reflection of kind of the current state of the state health plan, where I've grouped the chapters of regulation into categories. We have 3 chapters that I've labeled as largely outdated. On reflection, I think that second one, while it's an old chapter, which has only been used once since it was developed, I guess I'd probably say it's moderately outdated. A lot of the standards in that plan, even though the plan was developed in 2002, are still relatively up to date. But the other 2, clearly, they're old, and they really don't reflect the current reality in these areas. We have a couple of other plans that are dated, but actually not that outdated in terms of the actual standards themselves. Neonatal intensive care services is one that really just needs to come up to speed with the current thinking on perinatal system standards, which are something that are used by the Maryland Department of Health and also by MIMS in terms of designating the referral areas for newborns to come to when they need neonatal intensive care services. And the Comprehensive Care Facility Services Plan, as you can see there, that is currently in the process of being updated. We have 3 plan chapters that are older than 5 years. 5 years is an important marker in the statute, because the statute says we should be updating and taking another look at these state health plan regulations at least every 5 years. And then we have 4 chapters of regulation that we have updated in the last 5 years. And we have a new chapter that was developed relatively recently for a new category of healthcare facility, freestanding medical facilities. Chronic hospital services, we are actually, those have been lumped together with our regulations for comprehensive care facility services. With the update that's currently underway, we're looking to probably create a chronic hospital services regulation that is a separate regulation. So to put some context into kind of the priorities that we're going to outline for you, our sense of priorities, we've looked at a couple of things, not only the age of these chapters, which we've already spoken to, but also how frequently they get used. So we looked at CON applications that got a final decision or were withdrawn prior to a final decision because we do have a tendency for applicants to withdraw applications that are getting a negative recommendation. And we looked at those going back to 2011, and projects, the column there on projects is a little incorrect because these aren't account of applications. These are actually project reviews. So when we have a comparative review like we had earlier today on home health, that's counted as a single review because there's a single recommended decision or recommendation covering multiple applications. So what we see here is that we actually have comprehensive care facility services and general surgical services as our two most frequently used chapters. The other thing I would mention here is that this is the primary chapter of regulation that was used in these reviews. We often have projects, especially multifaceted hospital projects, that actually involve more than one chapter of regulation. So I've tried to produce this table, based on the primary chapter of regulation that was used in these reviews. And just to illustrate that, you see that general hospital services, the third chapter on the list, I've got 7 projects. But then when you look at this list, you have general surgical services, which often gets applied in reviewing hospital projects, the psychiatric hospital services chapter, and the rehabilitation hospital services chapter, and the cardiac surgery and PCI services chapter. Those don't have a high project review count, but they're all hospital projects. So that's just something to keep in mind when you're looking at what information that table is conveying. And then just to kind of give you an indication of what's in our pipeline, we have a pretty big pipeline of projects right now. And this is how this shakes out. This is, again, the primary chapter of regulation that will come into play in the review of these projects. So based on that information, I'm outlining here for your consideration what we think the priorities going forward should be, what chapters of regulation we should be looking to update and reorient first. Comprehensive care facility services, again, used frequently. It's pretty old at this point, 12 years old, and I'm rating it as moderately outdated. And it's an important chapter to look at in terms of improving alignment of CON regulation with the total cost of care payment model experiment that's underway in the state. And as I noted, we have adopted proposed regulations late in 2018, so those are going to be coming up for consideration soon. Psychiatric hospital services, this is an old chapter and it is largely outdated. Hasn't been used that frequently in the last few years, but it is a set of regulations. It's a project category that I believe is somewhat problematic because we have problems that we certainly need to try to address, I think, in developing and updating a state health plan chapter. Psychiatric or behavioral health patients are often identified as a major problem for hospital emergency departments in terms of creating bottlenecks, difficulty in moving them along to either psychiatric hospital placement or other appropriate programming. And there's kind of a perennial question about bed need for psychiatric services. Certainly the information that we look at that comes through the discharge database doesn't suggest that there are critical issues with bed capacity, and we certainly don't see the kind of proposals to expand psychiatric bed capacity over the last few years that you might expect if there were critical issues. But certainly anecdotally, we hear from the field that it is getting more and more difficult to identify appropriate bed capacity for placement. That's immediately available and accessible for these types of patients. Third priority, general hospital services. This is now a plan that's about 10 years old. It's moderately outdated. There's a couple of standards in there that certainly no longer reflect the current reality of the hospital payment model. It did in 2009, but no longer does. It also needs to be updated to reflect kind of the state of the art with respect to performance evaluation and quality measures used in the hospital field. It's medium frequency use, maybe medium to high in some ways, because we do have hospital projects that this sometimes is a secondary type of regulation that needs to be addressed. And it's obviously an important chapter of regulation to look at in terms of better aligning CLN regulation with our sister agencies' efforts in the payment model. Alcoholism and drug abuse, ICF services. As you'll recall, this is an area, and also the other two areas here on this slide, general hospital services and home health agency services. Our plan identified all three of these categories of healthcare facility as ones that we really want to think about whether CLN regulation is the appropriate regulatory model for achieving the objectives that I think we want in this area. For all three of these, the planning process that we went through in the past year would certainly suggest that there is a great concern with making sure that we do not have inappropriate applicants entering the market in Maryland, people who may be bad actors, poor performers. That was really an emphasis that we heard from the stakeholders in these areas across the board. So in terms of that third major area that Dr. Moffitt mentioned as part of the modernization report, this is where we really want to engage, and we'll be talking about this in future meetings. We want to engage with other agencies in the state to see if, and the stakeholders, to see if we can come up with some approaches to actually regulating market entry specifically, and perhaps doing that at a pace of market entry that would not create a chaotic situation in terms of licensure and certification that may be an alternative to the way that we're regulating market entry through certificate of need regulation right now. But I think pending those kind of discussions and reaching consensus on those different approaches, we think it makes sense to update these three chapters as kind of our 4th, 5, and 6 priorities. These chapters, I'm labeling these as medium priorities. I think we want to get to these fairly soon. Rehabilitation hospital services was updated about 6 years ago. It's low frequency use, and I don't expect that it's going to be a set of regulations that comes into use frequently in the future. But I think it is time to take another look at that. Neonatal intensive care, again, primarily we've got to update the perinatal system standards. That update work has already been done by the Maryland Department of Health, and really that's the main thing that we have to do with that chapter of regulation, is just bring those new system standards into that plan. Very low frequency use. We pretty much don't have any hospitals out there anymore that are really in a position to support a neonatal intensive care program. They just don't have the volume of delivery of newborns that would warrant that. About 10 years ago, we kind of looked at the last 2 Maryland hospitals that were in the ballpark in terms of doing that, and one of those has actually dropped out since then because they really couldn't maintain the level of care and service that was required. So I don't see on the horizon that this will come into use, but it's a simple upgrade that we should take care of. And general surgical services, we've recommended some fairly significant changes in the scope of CLN regulation in this area, and hopefully we will get some consideration of those changes by the legislature either this year or next year. We should go ahead and take a look at these. Again, not right away, but I consider it a medium priority, and especially if we can get some of the statutory changes or something similar to the statutory changes that we're recommending, we'll want to definitely move forward with adopting new regulations in that area. And these are the ones that I would consider low priority for updating. The first one's old, but but again, as I said, I actually think it's only moderately outdated. Very low frequency use, like neonatal intensive care. I do not see any hospitals in Maryland right now that are looking to establish a new obstetric service. A hospital that doesn't have one now that might want to get into that business. Just not something I see happening. The other three there in the middle are all fairly new updates. They're not services that we're looking to really restructure the CON regulation in this area. That's not part of our report, so I don't think we have to be concerned with those right now. And then again, chronic hospital services is something that I don't think is a high or even medium priority because, again, I don't think we're going to see projects in this area. As I indicate there, the policy direction that we would likely take is that this is a type of service that is phasing out and has been phasing out, and we really want to evolve comprehensive care facilities and nursing homes to really have the capabilities to deal with the type of patients that have been placed in these long-term care hospitals in the past. So this is a kind of a recommended timeline for addressing the high and medium priority state health plan chapters. Again, I think we've gone far enough with our work on the comprehensive care facility plan that we want to target completion of that by the end of the fiscal year, July 1st of 2019. In the next fiscal year, FY 2020, I think we want to seek to complete updates of our psychiatric hospital services plan. We're going to be initiating the process for updating that soon. So I think possibly in February, you'll be getting a presentation on that area. And then residential treatment centers are part of that plan. Whether we continue to have both of those areas addressed in that plan, we'll see. General hospital services, alcohol and drug abuse, and neonatal intensive care, which is an easy update. I'm projecting those for FY 2020, and then in FY 2021, we pick up the other kind of medium priority services, general surgical services, general hospice services, and home health agency services. And as I note there, depending on what sort of statutory reforms may occur over the next year or two, we might rejuggle that list or that timeline. I think this is not an overly ambitious plan or timeline. We have been able, with our staff, our planning staff, to maintain a pace of updating, 2 chapters a year in recent years. I'm really not really deviating from that. Again, we have 4 in 2020, but neonatal intensive care is a very simple update. So it will definitely take an all-hands-on-deck approach here to get this done, but I think it actually is realistic. And then just to touch on our procedural regulations, not actually part of what we would typically consider part of the state health plan, but obviously a very important set of regulations. And when we look at our modernization report, what we outlined there are creating an abbreviated review process for certain uncontested projects. That's a regulatory change that obviously we're looking to try to implement without statutory changes. But I think it's an important area that we want to consider in the procedural regulations. We also want to revise our performance requirements for approved projects and also establish a process, a simpler process for review of changes that applicants come back to us with after we give them a CLN. While they're implementing their project, certain changes do have to come back to you, but in these three areas, we're looking to establish regulations that allow for staff review of some of the simpler changes, and you have a more limited set of more substantive changes that you would have to review as a commission. And the other part of updating these regulations is that we have had statutory changes in recent years that need to be reflected in these regulations. The key ones are in cardiac surgery and PCI, regulatory oversight, and then also freestanding medical facilities and the legislation that really created the process for converting general hospitals to freestanding medical facilities. There's a few other smaller changes that need to be reflected in our regulations, changes that have occurred in statute. And this is just outlining an approach on those procedural regulations. At this point in time, I think we should move forward with the conventional approach that we've used with state health plan chapter updates. We have a stakeholder group that we typically convene to work with staff on developing drafts of state health plan regulations. We would typically release those for informal public comment, use that informal comment to develop proposed regulations that we would bring to you for adoption. And then after the formal promulgation process and formal comment, we would come back for permanent regulations. The procedural regulations obviously cut across all categories of project and provider. So rather than using a process similar to what I just described for use in state health plan chapter regulation, what I'm suggesting here is that we develop a draft update of those procedural regulations during the first half of 2020 and use a commissioner consultative group. So I'll take volunteers after this presentation. But using staff and the commissioners, let's put together an update of those regulations. And then in the fall, actually start convening, my vision would be we might be convening some small groups. In certain areas, we might convene a hospital group, a nursing home group, just focused on looking at those regulations and gathering input on how they think those will work. I'm really going to go out on a limb here and maybe even say we'll have a CON attorney work group that we convene to look at this. I think this is one area where that we would probably get some worthwhile input from those folks since they're experts on regulations. And then look to, after that process, look to come back and actually start the process of promulgating those updated regulations for the CON process itself. So that concludes my presentation. I'd be happy to answer any questions.
Thank you very much, Paul. As always, an excellent presentation. Ladies and gentlemen, are there any questions for Paul? Yes. Commissioner Thomas.
I know a state health plan can't do everything, but I was trying to find the section on dental, oral health. I missed it. Where would I find it?
You won't.
I won't?
Because we develop state health plan regulations for projects that we have to approve. And
So we go from birth to hospice.
Okay. Yeah. We're going to stay out of the dentist's office. We're going to try to do that.
In
I
fact,
know there are some people who are desperate to get in there.
an interesting part of our statute is that dental surgery, for example, is actually kind of carved out from the general regulation of surgical centers. So if you want to open a dental surgery center, you can write us a letter and say, I'm going to limit myself to dental surgery, and we'll say, okay, you promised. But so you won't find state health fund regulations for things that we don't regulate because we assume we would never use them.
Okay. Anybody, any further questions? Anything? Any observations? Anybody morally outraged? No,
we volunteered.
Okay. All right. Yes, one. Go ahead.
That as we address the procedural regulations, we have to think of how we, in a balanced way, engage the practitioners of those procedural regulations. They wouldn't be the deciders, but they have perspectives on them that I think are going to be important to hear.
Okay. Very good point. Thank you very much, Paul. Excellent presentation. Ben, do you have some upcoming initiatives you want to share for the commission? We have our next meeting in February. Was it February 21st, right?
Yes.
Right.
I don't have as comprehensive a list as normal today, but I'm sure we'll have a couple CONs. We will have currently on the agenda would be consideration of the COMAR 1024-20, the comprehensive care regulations that are currently under review. The earliest that could come before the commission is in February. We will have several telehealth presentations, one on this project I mentioned related to telehealth readiness that we have actually developed in collaboration with RTI. And we also will be, I believe, presenting on a telehealth grant. So more to come, but I would expect that we would need to reserve some time for a discussion of legislation. Megan outlined the plan, and please get back to us on whether you prefer Monday or Friday. But we do try to avoid them the Monday or Friday immediately after a commission meeting, because we can do that legislative review work at the regular meeting and save everyone an additional meeting a day or two later. So we likely will reserve some time for legislation, pending legislation that we want to request commissioner input on. So I recognize there's a bit of snow forecast. We promised to get you out of here by 4.
And we broke the promise. All right. All good things come to an end, and the snow is coming, and that's not necessarily a good thing. I'd like to entertain a motion to adjourn the meeting. Commissioner Wang, Commissioner McCarthy. All right. Well, you're third, actually. You are? Okay, very good. Do we want to have an extended discussion? I don't think we do. So all those in favor say aye. Any opposed? Didn't think so. Thank you. See you next month. What's that?
Get on your book so we can do our lunch, our 2019 lunch. Okay.
What's that? When do you want to do this?
We haven't set it up yet.
February sometime.
Okay.
Middle February.
Okay.
Good.